turn that on. Welcome. This meeting is being recorded, the October P&T committee meeting. We may have one or more committee members still attending, but we have more than a quorum, so pardon me, I had to go on mute for a second. Little seasonal cold. So we have a robust agenda, so I propose we get going. So if those in the audience are following along where you found the link to enter this meeting, there's also a copy of the packet of materials in the agenda. So I will try to call out the page numbers as we go through today. We're going to start off with roll call and introductions. So with that, we're going to start from the top of the order. Pat, we'll have you lead off.
Everybody, Pat DiMartino, faculty at OHSU, Division of PED-CMOC.
Welcome. Kat?
Hello. Yeah, can you hear me?
You bet. Hear you. Thank you.
Okay. Hi, I'm Kat Livingston. I'm the medical director of HealthShare of Oregon. I'm also a practicing family physician and preventive medicine physician.
Welcome, Kat. Stacy's our chair. Stacy?
Hey everybody, this is Stacy Ramirez. I'm faculty at OSU College of Pharmacy and the Chief Clinical Officer for Preventa Health.
Welcome, Stacy. And Tim.
Good afternoon. This is Tim Langford. I'm the pharmacy director with the Klamath Tribes.
Glad you could make it, Tim. Thank you. Bridget.
Yeah, my name's Bridget Bradley, and I'm a psychiatric pharmacist at Kaiser Northwest.
Welcome, Bridget. And Samara, I just made you co-host. Are you able to unmute your line?
Yep. Hi, I'm Samara Stevens, and I am a naturopath in mental health in North Portland.
Welcome. Jeannie? Don't hear you yet. I know you unmuted a moment ago. Are you able to unmute? I think she was in transit, so let's give her a minute. Doug, we'll go to you and come back to Jeannie at the end.
I'm Douglas Carr. I'm an internal medicine physician and medical director at Umpqua Health in Douglas County.
Welcome, Doug. Russ may join us. I haven't seen him yet, so Eriko, we'll turn it over to you.
Hi, I'm Eriko Nishi. I'm a practice family physician at OHSU.
Welcome, Eriko. Eddie.
Hi, good afternoon. Eddie Saito, faculty with Pacific University School of Pharmacy and clinical pharmacist with Virginia Garcia.
Welcome. Jeannie, I'm going to circle back to you. Are you back on and able to unmute your line? I don't see a microphone, so you might be on the phone or in transition. But Jeannie Savage is a medical director with Trillium. She is joining us today, so we'll pay attention to her line and get her introduced. So we'll move over to staff. Jennifer isn't able to join us today, so I'm Roger Citron. I'm the director of the Drug Use Research and Management Program. We help administer these meetings on behalf of the OHA.
Hi, everybody. I'm Trevor Douglas. I am the Pharmacy Policy and Programs Director at the Oregon Health Authority.
Hello, I'm Dave Engen, a clinical pharmacist with OSU's Derm team.
Hi, I'm Sarah Fletcher. I'm one of the P&T clinical coordinators for the OSU Derm team.
Hi, I'm Andrew Gibler. I am the Clinical Pharmacy Policy and Programs Manager for the Oregon Health Authority.
And Kyle isn't able to join us. Dan, were you able to get online? I've not seen him here yet, but we'll get back. Megan, turn it over to you.
Hi, I'm Megan Herring, a clinical pharmacist with the Derm team.
Good afternoon. I'm Deanna Moretz. I'm also a pharmacist with the OSU Derm team.
Hi, I'm Kathy Centena, and I'm also a pharmacist with the OSU Derm team.
Hi, my name is Sarah Servid. I am one of the P&T clinical coordinators with the Derm group.
Lan is taking a much needed vacation, so won't be with us today. Dee is also quite busy, not with us. Brandon, we'll turn it over to you.
Good afternoon, Brandon Wells. I'm the pharmacy program analyst for the fee-for-service program at OHA.
Ted also spread thin, so he's not going to be joining us. I didn't see Michael. Michael, were you on? Not hearing them. We have Rose Hong, a student on rotation with us. Rose?
Hello, my name is Rose Hong. I am a pharmacy student currently doing rotations with the Derm Group.
Welcome. And Jeannie, I saw you were able to get back on. Are you able to unmute and introduce yourself?
Yes, I am. Are you able to hear me okay?
You kind of sound like a fish underwater.
Yeah,
I hear you.
I'll be back and I'll be on a little more clear in just a second.
Great. Well, thank you. And we'll look for your line up. So thank you. So we may have one or two more join us, but I think we'll move on from introductions. Next is the conflict of interest declaration. All of the committee members and the staff have conflict of interest declarations on file with the OHA. And anybody providing public comment today has also been asked to fill out a short conflict of interest declaration form. If they're not with industry, we will call that out to the committee's attention, see if they have any questions about their any conflicts. And at this time, we'll open it up to see if any committee members have a new recent conflict they would like to disclose or any subjects they need to recuse themselves from. We will entertain that as we go through, but any conflicts that need to be brought forward? All right. Hearing none, we have the approval of the agenda and the minutes. Give me 1 second. So we have adjusted the top. When we first posted the agenda, we had some topics in a little slightly different order. We have amended that, and that we will be following the course of events. As I mentioned, we have quite a robust agenda, so we hope we get through it, but we may have to defer a topic or two depending on how much discussion and the timing of those. Backing up for 1 second, Russ Huffman, one of our committee members, are you able to unmute your line? I made you a co-host.
Hey there.
Hey there. Briefly introduce and we'll move on.
Yep.
Welcome.
My name is Russ Huffman. I'm a psychiatric nurse practitioner with Salem Health. Glad to be here. Sorry.
No worries. Very busy, and this is important, but it's volunteer work, so really appreciate you being here. So again, if you're following along in the packet of materials, the minutes from the previous meeting start on page 4. Those were sent out to the committee in advance, so they had a chance to review those. Does anybody have any edits that they would recommend for the minutes? And if not, we would take a motion to approve those.
So moved.
Thank you, Doug.
Second.
Thank you. All those in favor?
Aye.
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 Opposed? Abstain?
Abstain.
Because you weren't there. Thank you. Is that right?
Yeah.
Okay, perfect. Thank you so much.
Well, I'm distracting myself with my own video, so I'm going to go off video. And as we move on to the consent agenda, there are the first 2 topics on the consent agenda are posted independently from the packet of materials. This is the P&T annual report that's prepared based on the legislation for the legislature, and the CMS annual report, which reflects the work this committee does and some DUR requirements on behalf of CMS. Those are turned in at the end of June. If there's any discussion with the committee, we can have that, but we've included them just for awareness. We do also have the iron replacement literature scan, multiple sclerosis literature scan. Those have no new clinical information. We're planning to just review an executive session, and the oncology prior authorization that we add new agents to those as those come to market just saves us a little bandwidth. Anybody on the committee want to discuss any of these topics, or do we have a motion to approve?
Motion to approve.
Thank you, Russ.
Second.
Thank you, Pat.
All right. All those in favor?
Aye.
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 Anyone opposed? Abstain? All right. Thank you.
Great, thank you. So we're gonna start with the new meat and potatoes of new business, oral cystic fibrosis modulators. Those start on page 59 if you're following in the packet of materials, and we'll turn it over to Megan.
Thank you, Roger. So yes, I'm going to be presenting the class update and new drug evaluation. The purpose of this is to evaluate new evidence for the safety and effectiveness of the oral cystic fibrosis modulators in reducing respiratory symptoms or pulmonary exacerbations and improving quality of life, and then to evaluate the evidence and place in therapy of the newest CF modulator, vanzacaftor, tezacaftor, and deutivacaftor. or Alyftrek. And just a little bit of background with this class. Alyftrek, I apologize, I may use the brand name just for ease and time, but Alyftrek is the 5th oral CF modulator approved for the treatment of cystic fibrosis and the 4th combination therapy. These agents enhance the cystic fibrosis transmembrane conductance regulator, or the CFTR gene function, which is the underlying cause of CF. They include CF potentiators and correctors. You can see the different indications in this table. And as a reminder, the most common genetic mutation in the United States is the F508del mutation. So approximately 90% of CF patients carry at least one allele of the F508del mutation, and 50% are homozygous for the F508del mutation. In this table, the only other triple combination agent that is available is Trifactor or Elixacaftor, Tezacaftor, and Ivacaftor. And this has become standard of care for anybody with a responsive variant, and approximately 90% of persons with CEF are eligible for treatment with triple therapy. So the newest one on the bottom has a similar mechanism as Trikafta. It has 2 CF correctors and 1 potentiator, and is indicated for over 300 variants, representing over 90% of the US population. And it does have a Ivacaftor, which is a new CFTR potentiator that has a longer half-life than Ivacaftor. So this agent, compared to Trikafta, has once daily dosing. Trikafta has to be given twice a day. Next slide. For the class updates, looking for any new evidence, there were 2 systematic reviews that were included, mainly looking at triple therapy in patients that do have at least one allele for the F508del mutation. Overall, these systematic reviews concluded insufficient to low quality evidence supporting monotherapy or dual therapy, moderate quality evidence showing an improved quality of life with triple therapy, as well as demonstrating an improvement in absolute change in percent predicted FEV1 with triple therapy compared to control or placebo, and low quality of evidence that triple therapy, again, most of these studies are with Trikafta, demonstrate a decrease in pulmonary exacerbation, and moderate quality of evidence of no difference in adverse events between triple therapy and control. Next slide. There were new guidelines from the National Institute for Health and Care Excellence, or NICE. And NICE guidelines concluded that symptomatic care for CF can be burdensome and does not treat the underlying condition, and does recommend or conclude that the CFTR modulators are clinically effective, and particularly in those patients with at least one F508del mutation. And overall, the guidance recommends the use of these agents for routine use for anybody with a responsive mutation. They also had guidance for the newest agent, the Alyftrek, and concluded that there is enough evidence to support the benefits in patients 6 years and over with one or more F508del mutations. And lastly, they recommend to use the least expensive option of suitable treatments. There was one new safety alert for this class in December of 2024. The safety warning on drug-induced liver injury and liver failure associated with Trifacta was updated from a warning and precaution to a box warning. This medication can cause drug-induced liver injury, and the recommendations are to monitor liver function at baseline every month for the first 6 months, and then every 3 months for the next 12 months, and then annually. Next slide. So the new drug, vanzacaftor, tezacaftor, and dutaivacaftor. Again, the mechanism of action I mentioned, but it includes 2 CFTR correctors, vanzacaftor and tezacaftor, and these bind to different sites on the CFTR protein. So it's thought that they have an additive effect in facilitating delivery of the CFTR protein to the cell surface. And then Tivacaftor is a potentiator that increases the probability that the CFTR gene remains open. And so the currently labeled FDA indication is for patients 6 years and older with CF who have at least one F508del mutation or another responsive mutation in the CFTR gene. In your packet in the appendix, there is a list of all the responsive mutations that are included in the label, and it's, I think it's like 305 or something. Next slide. So approval of Alyftrek was based on 2 multicenter randomized active controlled non-inferiority phase 3 trials that were similarly designed. Sorry, this slide is a bit busy, but this includes study 102 and 103. The main difference was kind of the patient population. So in the inclusion criteria, you can see that study 102 included subjects with F508del heterozygous for the F508del and a minimal function mutation, and study 103 included patients with who were homozygous for the F508del or had a F508del residual function mutation or a gating or other trifactor responsive mutation. And so in this study, all patients received Trikafta during a 4-week run-in period, and only patients who tolerated that were randomized to Alyftrek or Trikafta for a 52-week treatment period. And the primary outcome in both trials was absolute change in percent predicted FEV1 from baseline through week 24. Among the enrolled population, again, like 96% of subjects had at least one copy of that F508del variant. And almost 90% of participants reported prior use of the other triple therapy, Elexacaftor, Tezacaftor, and Ivacaftor, which is Trifacta. So most of these patients had been on therapy with Trikafta. And overall, these studies included a stable CF population with a higher baseline FEV1 than a lot of the previous studies with the CF modulators. So you can see at the bottom, both trials demonstrated non-inferiority of Alyftrek to Trikafta for percent predicted FEV1 through 24 weeks. Next slide. For clinical safety, rates of discontinuations due to adverse events were similar between the groups at 3.8 and 3.7%. In this table, you can see the common adverse events that occurred more frequently with Alyftrek compared to Trikafta. The safety profile of Alyftrek appears similar to Trikafta and also includes that potential risk for drug-induced liver injury and liver failure that I mentioned. And so there is a boxed warning for drug-induced liver injury in its labeling. And in these trials, 1.5% of subjects discontinued due to elevated liver transaminases. Also, this drug is also metabolized by CYP3A4, and use with moderate to strong inducers or inhibitors should be avoided. So overall trial limitations, again, most participants did have prior use of triple therapy with Trikafta, and so there's kind of unclear generalizability to treatment naive or intolerant patients. Also, because of the run-in period, they had all demonstrated that they tolerated this tolerated therapy with Trikafta. And again, it was limited to, there were limited subjects with severe disease. And so this was a fairly stable cohort of patients with CF. This drug is approved for patients ages 6 and older. However, most of the participants were adults. And so the interpretation in the adolescent subgroup was limited because of that small sample size. Like all of these medications for the less common variants, approval is based on in vitro data that's submitted to the FDA. And lastly, based on this trial, there is insufficient evidence evaluating therapy on quality of life, survival, and pulmonary exacerbations. So in conclusion, there is moderate quality of evidence that Vanzacaftor, Tezacaftor, and Tivacaftor is non-inferior to Elexacaftor, Tezacaftor, and Ivacaftor on change from baseline in FEV1 through 24 weeks. There is insufficient evidence evaluating it in subjects with the non-F 508 del responsive variants. Guidelines from NICE do recommend routine use of the oral CF modulators based on evidence of clinical benefit, and since symptomatic care for CF does not treat the underlying cause. And lastly, the majority of data on efficacy and safety of these medications includes patients with at least one F508 del mutation. And there is a concern because of racial and ethnic variations in variants causing disparities in access to effective treatments for those more rare variants. So our recommendations are to maintain Alyftrek as non-preferred on the PDL and include it in our existing PA criteria, ensuring use is for one of the FDA-approved mutations and according to FDA labeling. Evaluate comparative costs in executive session, and to update the PA criteria with new genetic mutations in the labeling for each of the medications and dosing, and to address appropriate step therapy based on the current NICE guidelines. So here you can see our PA criteria, which is in your packet. For the most part, the changes were just adding the new medication into the criteria and updating all of the tables to include the newest FDA-approved genetic mutations. Next slide. We do continue to ask that these are prescribed by a pulmonologist or from a practitioner at a CF center. That it's for approved CFTR gene mutation. And then the biggest change is, sorry, you can't see the change here, but in the previous PA criteria, before asking about CYP inducers, asked if a patient was on all of the symptomatic care, including Dornase alpha, hypertonic saline, and inhaled antibiotics if appropriate. And kind of based on the changes in standard of care and the NICE guidelines, we are recommending to remove that question from the PA criteria. Next slide. And then we continue to have renewal criteria, ensuring that patients are having a response from therapy, which is seen by either an improvement or a lack of decline in lung function, or a reduction in pulmonary exacerbations. And then lastly, to make sure that liver function tests are being monitored appropriately. And that's it.
Thank you, Megan. Any questions from the committee for Megan? We do have one representative from Vertex that would like to provide public comment, but we'll entertain your questions of Megan first.
They can correct my pronunciation of the newer drug.
Hearing none, there we go. Jessica J. with Vertex, are you able to unmute your line?
Yes, I can.
All right, we hear you loud and clear. The floor is, Jessica's representative from Vertex, as I mentioned. The floor is yours for 3 minutes.
Thank you. Good afternoon, everyone. My name is Jessica J. I'm a pharmacist by training and Associate Director of Field Health Economics and Outcomes Research with Vertex Pharmaceuticals. We agree with the proposed recommendations and criteria for Alyftrek. If anyone has any questions, I'm more than happy to answer them. If not, I would like to yield my time back, and thank you everyone for your time.
Great, appreciate it. Any questions from the committee? Okay. With that, we'll bring the recommendations back up on the screen. So as you can see, maintain Alyftrek as non-preferred, include the clinical PA criteria ensuring it's FDA approved for the correct mutations according to the labeling. Other changes as Megan went over. We're going to look at the cost in executive session, and we'll also update the PA with the new indications and appropriate dosing. Any discussion? Okay. Do we entertain a motion?
Motion to approve.
Thank you, Pat.
Second.
Thanks, Doug.
All right, all those in favor?
Aye.
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 Oh, sorry. Opposed? Abstain? All right, thank you all.
Great. We're going to move on to the targeted immune modulators for asthma and atopic dermatitis. We have both the new drug evaluation and the class update. If you're following the packet, I believe we're starting on page 96. And Deanna, I think were you leading off?
Yes, I am. I'm ready to go.
All yours.
All right, thanks. If we can go to the next slide, please. So this is a pretty heavy topic, as Roger mentioned. So we're going to be looking at the new evidence for the targeted immune therapies that are approved for management of asthma and atopic dermatitis, but we're specifically going to look at the non-pulmonary indications, which includes prurigo nodularis, chronic rhinosinusitis with nasal polyps, chronic spontaneous urticaria, eosinophilic granulomatosis with polyangiitis, and hypereosinophilic syndrome. To make this go a little bit smoother, I'll refer to these as their abbreviations going forward. And then we have two new drugs that have approval for atopic dermatitis. So first we'll talk about nemolizumab, and then Dan will jump in with the lebrikizumab new drug evaluation. So if we could go to the next slide, please. Just wanted to provide an overview of what drugs we will specifically be talking about. So these are the drugs that have the indications for other diagnoses that I just went over. This table is in the packet on page 81, and the two new drugs are italicized and highlighted in red. If we can go to the next slide. So this class update includes 1 systematic review and 6 clinical guidelines for the non-asthma indications, and then we'll move into atopic dermatitis, which I think there was 8 clinical guidelines for the atopic dermatitis. So we'll start with the DERP systematic review, which is the Drug Evidence Review Project. So they did a review in 2024, which updated a 2021 update, just looking at the TIMs for non-asthma inflammatory conditions. So when they looked at chronic rhinosinusitis with nasal polyps, there's 3 drugs that are approved for that, and all of the randomized controlled trials compared the drugs to placebo, and each of the TIMs showed that they improved nasal congestion and nasal polyp scoring. They also looked at omalizumab for improvement in urticaria. And again, that showed efficacy compared to placebo. And then there was 1 placebo-controlled trial that looked at memolizumab for add-on therapy to corticosteroids for EGPA. If we can go to the next slide, the additional results from the DERP systematic review. So there's 1 head-to-head study comparing benralizumab to mepolizumab, and it showed that there's no advantages one over the other for EGPA. And then looking at HES, there was 2 randomized controlled trials that showed that mepolizumab is effective. And then we had 2 randomized controlled trials with dupilumab looking at prurigo nodularis symptom improvement compared to placebo. So that's it for the systematic review. Moving into the guidelines. So the first guidance is from the AAAI, which was a joint task force of the American Academy of Allergy, Asthma, and Immunology and the American College of Allergy, Asthma, and Immunology. So the first guidance was looking at chronic rhinosinusitis with nasal polyps, and they recommend starting with nasal corticosteroid spray rather than no inhaled spray. That's part of our PA guidance already, is making sure that people have failed nasal corticosteroids before they move on to dupilumab. And they also recommend biologics rather than no biologics. Next slide, please. Now, for chronic urticaria, this is currently not funded, but based on the benefit plan update, we were bringing forward some PA changes. So I know this is old guidance, but it's because we've never looked at chronic urticaria because it's not funded. So starting with the 2014 guidance, there was three recommendations. For chronic urticaria, the recommendation is to start with second-generation antihistamines because they've been proven to be safe and effective, and they're considered first-line agents. If people aren't responsive to the antihistamines, then leukotriene receptor antagonists are recommended. And then finally moving into omalizumab if the chronic urticaria is refractory to therapy. So this is important because it's part of our PA update, which is why I'm bringing this forward now. If we go into the next slide, it's the NICE guidance from 2015, and they recommend omalizumab as an add-on for treatment of CSU only if there's documentation of the weekly urticaria activity score and if the patient has not responded to standard treatment with either antihistamines and leukotriene receptor antagonists. And then they recommend omalizumab as long as it's being managed by a specialist in dermatology, immunology, or allergy. If we go on to the next slide, this is the guidance for EGPA. And the guidance comes from the American College of Rheumatology and the Vascular Foundation. So the evidence is not that great for mepolizumab. So most of their recommendations are conditional and they're based on low to very low quality evidence, as you can see outlined here on the slide. They do recommend that if methotrexate or azathioprine or mycophenolate haven't worked, or steroids, to start mepolizumab. Particularly if they relapse on that therapy or if they're using steroids to start the mepolizumab over adding the methotrexate, azathioprine, or mycophenolate. If we could go to the next slide. This is the EULAR guidance from 2022, and they recommend mepolizumab for remission induction in patients that have relapsing or EGPA that's refractory to glucocorticoids. And that's a moderate recommendation based on moderate quality evidence. And then looking at NICE for prurigo nodularis, NICE does not recommend dupilumab for prurigo nodularis. That's because the clinical trials did not include many of the treatments, such as oral steroids or immunosuppressants that are usually used to manage prurigo nodularis. So NICE felt like those limitations in the trials made it difficult to generalize dupilumab as a first-line treatment. So that's why they don't recommend dupilumab right now. If we go on to the next slide. Okay, that's the end of the non-asthma and non-atopic dermatitis guidelines. Now we'll be moving into atopic dermatitis updates. So I didn't talk about the different TIMs that are approved for atopic dermatitis. Those are included in your packet, but primarily, we're talking about newer JAK inhibitors, as well as the two new drugs that Dan and I will be reviewing. So NICE issued some guidance for the using abrocitinib, upadacitinib, and tralokinumab. They're all recommended if the atopic dermatitis has not responded to a systemic immunosuppressant, such as methotrexate. Dan will be talking about lebrikizumab in just a minute, which is recommended for treating moderate to severe atopic dermatitis in patients that are age 12 years and older if it hasn't responded to either a systemic immunosuppressant or if they're not eligible for dupilumab or tralokinumab. The next slide talks about the AAAI, ACAAI, and they recommend dupilumab or tralokinumab for patients that have moderate to severe atopic dermatitis that's refractory to topical steroids or calcineurin inhibitors. They also recommend the oral JAK inhibitors, so abrocitinib or upadacitinib, if they haven't been able to have success with topical treatments such as the steroids or the calcineurin inhibitors, or dupilumab or tralokinumab. Next slide, please. The American Academy of Dermatology has some recommendations for treatment of atopic dermatitis, and they recommend dupilumab and tralokinumab. That's based on moderate quality evidence. And then they came out with some recommendations for 3 JAK inhibitors, Baricitinib is not approved for use in atopic dermatitis. So, but abrocitinib and upadacitinib are also recommended for adults with moderate to severe atopic dermatitis. Next slide, please. So looking at the Canadian Drug Agency, so they recommend upadacitinib or abrocitinib if patients have not tolerated an oral immunomodulator such as methotrexate or cyclosporin. And then they have some guidance about renewal. So they recommend that the patients show improvement using the ESI 75 scoring after 20 weeks of treatment. They do recommend dupilumab as second-line therapy for treatment of patients who are aged 6 months and older with moderate to severe atopic dermatitis if they haven't gotten relief from the topical agents. Next slide, please. Okay, so we have some new indications, and this is going to affect the PA changes as well. So dupilumab received expanded FDA approval in April 2025 to use in patients 12 years and older with chronic spontaneous urticaria who are symptomatic despite antihistamine treatment. And then also dupilumab got a recommendation approval from the FDA for bullous pemphigoid, which is a painful autoimmune blistering condition that has intense itching. There are no other TIMs that are FDA approved for this particular condition. And then mepolizumab joins dupilumab in having expanded FDA approval to use for people with COPD and an eosinophilic phenotype. All right, so let's go into the new drug review for nemolizumab. If we could go to the next slide, please. This is an IL-31 receptor antagonist, and IL-31 is involved in itching, inflammation, changes to the skin, and fibrosis. And as I mentioned previously, it has 2 FDA-approved indications. The first is adults with prurigo nodularis, and a loading dose is recommended. It's weight-based, depending on if they're over 90 kilos or under 90 kilos. And then in patients that are 12 years and older, it's recommended for moderate to severe atopic dermatitis in combination with the topical agents. And it's loading dose, 30 milligrams every 4 weeks. And if the patient does well, after 16 weeks, the dose can be reduced to 30 milligrams every 8 weeks if they've achieved clear or almost clear skin. We could go to the next slide. So there were 2 trials that looked at the clinical efficacy in patients that had prurigo nodularis. Relatively small trials because not many people have this condition, and it was all in adults. They had to have an itching score greater than 7, and they had to have more than 20 prurigo nodules. And they also had to have an investigator global assessment score greater than 3. The duration of the trial was 16 weeks, and there was 2 co-primary outcomes. The percent of patients that had an itch response as measured by a reduction of more than 4 points or more in the prurigo, the peak pruritus numerical rating scale, and then also the percent of patients that had an IGA response, which was 0 or 1, clear or almost clear at week 16. And you can see, compared to placebo, that nemolizumab was superior in both of those outcomes. We could go to the next slide, please. So the trials for atopic dermatitis efficacy were also placebo-controlled, much larger trials compared to the prurigo nodularis, and they enrolled patients that were 12 years and older with moderate to severe atopic dermatitis. Again, this was a 16-week trial, and the 2 co-primary outcomes were the percent of patients with an IGA response, as well as the patients that had an ESI 75 response. And again, nemolizumab was superior to placebo in both of those outcomes. If we could go to the next slide. So some of the trial limitations, For prurigo nodularis, it seems to disproportionately affect more Black than white patients. And unfortunately, the people that identify as Black were underrepresented in both randomized controlled trials that looked at that. In addition, it was a short-term trial, only 16 weeks, so we don't have evidence about the long-term safety and efficacy for prurigo nodularis. The atopic dermatitis trial was also short-term with a predominantly white enrolled population. In addition, in this trial, patients that had received dupilumab and did not improve on dupilumab were excluded from enrollment in the trial. And we don't have any comparative trial with other TIMs that are approved for atopic dermatitis, so it's difficult to evaluate the place in therapy for nemolizumab until we have some more comparative efficacy trials. In terms of safety, in the prurigo nodularis, headache was the most common side effect, and then there was also some exacerbation of atopic dermatitis or eczema. If we go to the next slide, when they looked at the adverse effects in patients with atopic dermatitis, headache again was the most prominent adverse effect, in addition to some muscle aches, some itching, and problems with the joints. Just as a reminder, this is a immunomodulator, so administration of live vaccines should be avoided during treatment with nemolizumab. And it's also interacts with the CYP450 enzymes. So patients that are on drugs that have a narrow therapeutic index, such as warfarin or cyclosporin, may need a dosage modification if they start this medication. Excuse me, has Dan joined? Can we switch to Dan?
I'm here.
He has.
Yay.
All right. Yeah, so I conducted and we'll discuss the new drug evaluation for lebrikizumab, brand name Ebglyss, which is a Eli Lilly product approved in September 2024. So similar to the drug that Deanna discussed, lebrikizumab is an interleukin-13 directed monoclonal antibody that inhibits signaling involved in pro-inflammatory cytokine release and the pathogenesis of atopic dermatitis. It is approved for the treatment of atopic dermatitis in adults and pediatric patients 12 years of age and older, or weigh at least 40 kilograms, with moderate to severe atopic dermatitis whose disease is not adequately controlled with topical prescription therapies, or when those therapies are not advisable. There are two phases in the package insert dosing recommendations. So one is an induction phase where the drug is dosed 250 milligrams subcutaneous every 2 weeks for 16 weeks. And then the providers would evaluate for a response and continue on a maintenance dose of 250 milligrams subcutaneous every 4 weeks thereafter. It is approved for use with or without topical corticosteroids or calcineurin inhibitors in those patients. The next slide. The FDA's review of lebrikizumab included 4 randomized controlled trials. 3 of these trials were 16-week induction trials, and there was 1 longer maintenance phase trial that I'll just go through briefly. The first 2 trials that I want to discuss are the Advocate 1 and 2, which were identical in design, and they enrolled about 400 patients in each trial. Participants were randomized 2-to-1 to lebrikizumab or placebo. An important feature of this trial was that co-administration of topical corticosteroids or calcineurin inhibitors was actually not permitted in this trial. It was a 16-week induction trial, and they evaluated the efficacy across a variety of different outcomes that measure atopic dermatitis, skin involvement, pruritus, sleep, and quality of life. And I'll just discuss 2 of the more common outcomes that were reported in this trial and the other trials. Primary outcome was the percent of participants who had an investigator's global assessment severity score response. The IGA is a clinician-reported outcome measure that has been used to evaluate severity of atopic dermatitis at a given point in time on a 5-point rating scale from 0 to 4, with a response defined as a 2-point improvement from baseline and a score of 0 or 1. So you can see in this table that in both trials, lebrikizumab was significantly superior to placebo. With the first trial, 43.1 versus 12.7% of participants having a response, with an absolute difference of 29.7 percentage points, the number needed to treat of 4. In the other trial, 33.2 versus 10.8% of participants had an IgA response with an absolute difference of 21.9% and number needed to treat of 5. Another commonly used secondary endpoint was the percentage of patients with a 75% improvement in the EASI at week 16. EASI is the Eczema Area and Severity Index, which assesses severity and body surface area involvement across different anatomical regions and summarized in a composite score that ranges from 0 to 72 points. Similar to the primary outcome, lebrikizumab was significantly superior to placebo in these trials. With the first trial, 58.8 versus 16.2% of patients in the lebrikizumab and placebo respectively having a response, with an absolute difference of 42 percentage points or number needed to treat of 3. In the Advocate 2, 52.1 versus 18.1% of participants had a EASI 75 response, an absolute difference of 33.3%, number needed to treat of 3. So let's go to the next trial. This trial was called the ADHERE trial. Similar to the other one, it's a double-blind, placebo-controlled, multi-center trial, randomized 228 participants at a 2-to-1 ratio to lebrikizumab or placebo. An important differentiating feature of this trial was that it allowed the co-administration of low to mid-potency topical corticosteroids or calcineurin inhibitors. It was a 16-week induction trial that evaluated a similar array of efficacy outcomes. And so I've summarized the primary and the key secondary outcome from this trial. As you can see in this table here, lebrikizumab was superior to placebo with 41.2% versus 22.1% of participants having an IgA response, with the absolute difference of 18.3%, number needed to treatment of 6. The treatment effect in this trial was slightly lower than the treatment effect in the other 2 trials I discussed, and probably attributed to the fact that these participants were allowed to co-administer topical steroids at the same time. So it probably has a less effective when used in this fashion. Similarly, with respect to the EASI 75, 69.5% versus 42.2% of participants had an EASI 75 response, absolute difference of 26.4 percentage points, number needed to treat of 4. So moving on to the next trial. This was actually a trial that evaluated participants who actually had a response after 16 weeks induction. They were re-randomized to 2 different dosing regimens to evaluate a maintenance dose of lebrikizumab versus placebo. They looked at 2 different dosing regimens. One was 250 milligrams every 4 weeks, which is actually the FDA approved dose now for maintenance, and then 250 milligrams every 2 weeks. They looked at 291 participants over an additional 36 weeks, so a total treatment time of 52 weeks. When we look at the proportion of participants who were able to maintain a response with respect to the EASI 75 and the IgA response, both the every 4 weeks and the every 2 weeks regimen had similar efficacy relative to placebo. So I've summarized the FDA endorsed dose of every 4 weeks versus placebo, with the absolute difference in the EASI 75 being 15.3%, number needed to treat of 7. And then IgA response, absolute difference was 29%, or number needed to treat of 4. So the final trial was not reviewed by the FDA, but was included in our synthesis. It's called the ADHERE-J. It's very similar to the ADHERE study, but it was actually conducted exclusively in Japan. And so they actually looked at 2 different doses of induction versus placebo. The results were fairly similar to the other induction studies that were reviewed by the FDA. So I won't go into any great detail on this particular study, but just to add to the evidence base around this drug. So next slide. These trials were relatively well conducted. They had a low risk of bias in the domains that we evaluated. Their main limitations were related to the external validity of the studies. These trials were predominantly a limited duration of mostly 16 weeks with one 52-week maintenance trial. Trial populations, with the exception of the trial in Japan, were predominantly white patients. And then similar to the other drug, none of these trials did any sort of direct comparisons to other targeted immune therapies for atopic dermatitis. In terms of the safety, lebrikizumab was relatively well tolerated in these trials with very low rates of serious adverse events. In terms of non-serious adverse events, the most commonly encountered adverse effects in the induction trial was conjunctivitis, with 6.3% of patients experiencing that in those patients receiving lebrikizumab versus placebo, 1.7%. And in the maintenance trial, participants receiving lebrikizumab were more likely to report COVID-19 with 19.3% versus 3.3%, conjunctivitis about 6% versus 1.8% for placebo, nasopharyngitis 7.6% versus 5% for placebo, and then herpes infection 5.9% versus 3.3% for placebo. All right. And I think back to Deanna. All right.
Thanks, Dan. Nice
Yep.
job. All right, so there are a number of recommendations for this class. First, we want to update the PA criteria for the TIMS to include those 2 new drugs that we just discussed, as well as the expanded indications for dupilumab and mepolizumab. We'd like to maintain nemolizumab and lebrikizumab as non-preferred on the PDL. And then we'd like to revise the PA criteria to define specific medical necessity and appropriateness criteria for chronic spontaneous urticaria, which, as I mentioned earlier, is currently not funded. So we'll extend it to the patients that have the EPSDT benefit, and then in 2027, we'll be able to easily modify the PA criteria when the benefit plan update changes go into effect. The other thing we want to do is remove the requirement for co-prescribing of EpiPen for all the TIMS. When we first looked at the TIMS for autoimmune disorders, there were concern about the risk of anaphylaxis with their administration. But as a reminder, most of the anaphylaxis is due to the immunogenic properties of the protein components. So fully human monoclonal antibodies like dupilumab, which consist of almost entirely 99% human components, are associated with a lower risk of anaphylaxis, excuse me, compared to something like omalizumab, which carries 10% of murine elements. So only 2 TIMS have box warnings for anaphylaxis right now. That's omalizumab, and the overall rate of anaphylaxis with that is 0.2%, and reslizumab, and the overall rate of anaphylaxis with that is 0.3%. So we would like to just maintain the EpiPen requirement just for omalizumab. And then the other thing we'd like to do is, based upon recent guidance, remove the trial of an oral immunosuppressant in patients that are adolescents or pediatrics, and then we'll review the drug costs in executive session. So if we'll go to the next slide, the PA criteria, I believe, begin on page 116 of the packet. I'm just going to briefly go over the changes. So the first one is the table 1, which is the FDA approved indications and ages. So you see that we've added lebrikizumab and nemolizumab, and then also updated the new indication for mepolizumab for COPD. And you can see that dupilumab is the only other drug in this class that's approved for COPD. And then also adding the indication for dupilumab for bullous pemphigoid. And then if we go to the next slide, we added the recommended first-line conventional treatments for chronic spontaneous urticaria based on the guidelines that I went over. So at least a 4-week trial of a second-generation antihistamine. There is some evidence that increasing the dosing of the second-generation antihistamines may help ameliorate the symptoms of spontaneous urticaria. And then also we would like them to try a 4-week trial of a leukotriene receptor antagonist before moving into a targeted immune modulator. We could go to the next slide, please. So table 4, we updated the baseline required documentation for chronic rhinosinusitis with polyps. So making sure that this is also based on the guidance. And then the same thing with the chronic spontaneous urticaria, just adding that to this table of what the baseline scores should be. Next slide, please. So just to highlight the changes to the PH criteria, I didn't put them all in the slide, but for our initial request, we moved the renewal question earlier in the assessment. We're going to modify the stipulation for concurrent EpiPen only to apply to patients that are getting omalizumab, and that's based on the manufacturer labeling. We removed the question earlier about concurrent TIM therapy, so that's now question 9. And then change question number 18 for the duration of approval based upon the indications. So for the 4 indications there, we'll do 12 months, but for chronic spontaneous urticaria, the NICE guidance recommended 6 months. So that's how we were revising the criteria. The next slide talks about changes in renewal criteria. So as Dan and I both pointed out, for lebrikizumab and nemolizumab, as well as tralokinumab, after 16 weeks of treatment, the dosing can be modified to either every 4 weeks or 8 weeks. So we included that in the renewal criteria to make sure that that assessment takes place at 16 weeks of treatment. And then we clarified question number 6 in the renewal criteria to include documentation of failure to have benefit with conventional first-line treatments for patients with either asthma or COPD. And then finally, we added a question about renewal of omalizumab for spontaneous urticaria, depending on the response to therapy. And that's based on the 2015 NICE guidance, which recommends that if they're not responding to therapy, stopping it after the 4th dose. And then if they are responding, to only give 6 doses for spontaneous urticaria. So that's a lot that I've went through. There's a summary again of the recommendations, but at this point, I would open it up to any questions from the P&T committee. I know I went through that rather quickly.
Lots of information, Deanna and Dan. Great job. Any questions from the committee, Deanna or Dan?
All right, I think we have lots of public comment, don't we?
We do have a fair bit of public comment. We have Carla McSpadden from Galderma. Are you able to unmute your line?
Yes, can you hear me?
Hear you loud and clear, and the floor is yours for up to 3 minutes.
Okay, great, thanks. My name is Carla McSpadden, a pharmacist employed with Galderma, and appreciate the opportunity to speak about Nemluvio, generic name nemolizumab. As you heard, Nemluvio is approved for prurigo nodularis and atopic dermatitis, and it's the first and only drug to target IL-31, representing a new mechanism of action. Reminder that it's the first atopic derm treatment dosed every 4 weeks, with maintenance dosing extended to every 8 weeks for responders. As for how many AD patients will respond and use the every 8-week dosing, all we know at this point, until there is longer real-world utilization, is that in the trials, 37% of patients responded with skin clearance at the 16-week mark and moved into the phase of the study that evaluated every 8-week dosing. And even more, over half of patients have achieved skin clearance after 16 weeks in the long-term extension study. We presented interim 2-year long-term extension study results for both PN and AD this summer. The number of responders showing cleared skin, lessened disease severity, reduced itch, that continues to increase. and Nimluvio continues to show good tolerability with a similar safety profile as the initial studies. To clarify the drug interactions, a study with CYP450 substrates has been done, and there were no clinically significant interactions. This has been included in the most recent PI. And to clarify the clinical practice guidelines, Nimluvio has been strongly recommended by the American Academy of Dermatology when used in combination with topicals per their focused update for their guidelines this summer. Now, all of the advanced therapies have similar recommendations per AAD. And the traditional systemic immunosuppressants like methotrexate, et cetera, those are only conditionally recommended. So Galderma is respectfully requesting that Nimluvio have parity access to the other biologics, similar preferred status, similar clinical criteria. And the rationale for this request is first, to offer a different mechanism of action on the PDL and IL-31. Second would be the clinical benefits in itch, skin, and sleep that Nimluvio offers. And third, the potential value with responders extending that dosing interval to every 8 weeks as recommended in the PI, which would equal 6 pins per year for maintenance. Happy to answer any questions.
Great. Thank you very much, Carla. Committee, do you have any questions for Carla McSpadden? All right. Again, thank you for your time. Next, we have Catherine Disney from Amgen. Catherine, are you able to unmute your line?
I am, yes.
All right. The floor is yours for up to 3 minutes.
Thank you. Good afternoon, everyone. My name is Catherine Disney. I'm a pharmacist with Amgen Medical Affairs. Thank you for the opportunity to provide information on Tezspire or tezepelumab echo today. Tezspire is a first-in-class severe asthma biologic that blocks TSLP, an epithelial cytokine located upstream in the inflammatory cascade. It is indicated for the add-on maintenance treatment of adult and pediatric patients aged 12 years and older with severe asthma. Of note, Tezspire is not indicated for the relief of acute bronchospasm or status asthmaticus. Importantly, Tezspire is the first and only biologic for severe asthma without phenotypic or biomarker limitations within its approved label, meaning that patients do not have to have elevated serum eosinophils or perennial allergen sensitization to qualify. Tezspire clinical trials programs encompassed a broad, all-comers severe asthma patient population. Treatment resulted in significant improvements versus placebo in asthma exacerbations, lung function, asthma symptom control, and health-related quality of life. Reductions in the AAERs were observed across biomarker levels and clinically relevant subgroups, including blood eosinophil levels and allergic status. Tezspire also has an established safety profile. The most common adverse reactions occurring in at least 3% of patients include pharyngitis, arthralgia, and back pain. Tezspire is included in the 2025 GINA guideline recommendations as an add-on biologic therapy option for patients both with type 2, allergic and/or eosinophilic asthma, and non-type 2 severe asthma. I'd also like to note that there is a supplemental BLA that has been filed with the FDA for the potential use of Tezspire in adults with chronic rhinosinusitis with nasal polyps, with an anticipated PDUFA date of October 19th, 2025. Safety and effectiveness in this population have not been established at this time. The issue I'd like to address today, however, is access to Tezspire for severe asthma patients within Oregon Medicaid. Currently, no asthma biologic therapies are listed as preferred on the PDL. Existing approval criteria appear to require diagnostic confirmation of eosinophilic or allergic asthma, question 14, which does not align with Tezspire's FDA-approved label. The criteria do not clearly indicate that Tezspire is an appropriate option for both allergic and eosinophilic asthma without the need for diagnostic biomarkers. This could create unnecessary barriers for access to Tezspire. In summary, Tezspire significantly reduced asthma exacerbations in clinical trials, which included a broad population of severe asthma patients, irrespective of key biomarkers. Therefore, I respectfully request the committee to 1, clarify the approval criteria for biologics to reflect Tezspire's indication, removing unnecessary biomarker requirements, and 2, consider adding Tezspire as a preferred agent on the PDL, ensuring equitable access for all eligible patients with severe asthma. Thank you very much for your time.
Thank you, Catherine. It's like you practiced that right down to the wire. So, any questions from the committee? or from my team, from the authors? Any questions? All right, thank you for your time.
Thank you.
Next, we have Valerie Ng from Leo Pharma. Are you able to unmute your line?
Yes, can you hear me okay, Roger?
Yep, hear you loud and clear, and the floor is yours.
Perfect, thank you. Good afternoon, everyone. I'm Valerie Ng. I'm a pharmacist with the Field Medical Affairs at Leo Pharma, and I'm here to discuss Adbry or tralokinumab, and it is the first and only fully human biologic developed to specifically neutralize interleukin-13 or IL-13, which is a key driver of inflammation in atopic dermatitis. As Deanna had mentioned, Adbry has been strongly recommended as a first-line systemic therapy for moderate to severe atopic dermatitis within the guidelines that Deanna mentioned from both AAD and also Quad AI. And this recommendation is actually backed by robust long-term data, one of them being a 6-year study which confirmed no new safety signals and showed durable disease control with 93% of patients achieving at least that 75% improvement from baseline in their atopic dermatitis. And this effectiveness is actually further proven in the real world with both biologic naive and biologic experienced patients with over 55 published case series from around the globe. Another key advantage of Adbry is its flexible dosing, which Deanna had mentioned, which can create significant savings. So patients can often reduce their maintenance dose from every 2 weeks to every 4 weeks. And this is not just on the label. Actually, real world evidence shows nearly a third of patients make this switch, providing that 50% organic cost savings for both payers and patients each month. And that significant savings benefit was actually recently highlighted in an external payer trend report independent of Leo Pharma. So due to these clinical and economic value mentioned, we'd like to respectfully request the committee to consider adding Adbry or tralokinumab to the PDL as a preferred product for Oregon Medicaid patients suffering from moderate to severe atopic dermatitis who had an inadequate response to topical prescription therapies. Thank you all very much for your time, and I'm happy to answer any questions.
Thank you, Valerie. To the committee, do you have any questions for Valerie? All right, thank you very much. Next, we have Adam Furman from Sanofi. Adam, are you able to unmute your line?
I am. Can you hear me?
You bet. Loud and clear, and the floor is yours.
Awesome. Thank you. So good afternoon, everyone. I am Adam Furman. I'm a pharmacist on the Medical Value and Outcomes team at Sanofi. And I wanted to thank you for the opportunity to present information on dupilumab or Dupixent. And this is a monoclonal antibody that inhibits IL-4 and 13, which play key roles in the inflammatory pathways involved in type 2 inflammation. So as the committee is aware, Dupixent is currently approved within 8 different indications, including most recently CSU and bullous pemphigoid in adults. So today I'm going to focus on dupilumab's role in treating CSU. Dupilumab's efficacy in CSU was demonstrated in the CUPID clinical trial program based on the results of 2 pivotal phase 3 trials, CUPID A and CUPID C, which evaluated dupilumab in biologic naive patients who were inadequately controlled on H1 antihistamines. Both of these trials were randomized, double-blind, and placebo-controlled, with the primary endpoint being change in baseline or change from baseline in the weekly itch severity score, or ISS-7, and a key secondary endpoint being change in weekly urticaria activity score, also at week 24. Of note, the trial included patients with both moderate to severe CSU with a UAS7 of greater than or equal to 16 and an ISS7 of greater than or equal to 8 in the 7 days before randomization. So this is slightly different than what is listed in Table 4 of the agenda packet and was put up on the slides for the table titled Required Baseline Documentation of Disease Severity. In terms of efficacy, key results from CUPID A and C demonstrated treatment with dupilumab led to significantly greater improvements than placebo at week 24 for both ISS-7 and UAS-7. In addition, at that week 24 mark, a higher proportion of patients treated with dupilumab compared to placebo achieved both well-controlled CSU symptoms, as indicated with a UAS-7 of less than or equal to 6, and complete resolution of CSU symptoms, as indicated with a UAS-7 of 0. Now, regarding safety in CSU, Dupixent demonstrated a safety profile consistent with its other indications, with no new safety signals identified in the CSU trial population. However, please refer to the full prescribing information for complete safety details. So just really quick, in conclusion, Dupixent represents an important therapeutic option for CSU in patients who have inadequately controlled disease despite use of H1 antihistamines. And this was demonstrated by its efficacy in the CUPID clinical trial program. I respectfully request that committee consider prior authorization disease severity criteria that aligns with the clinical trial inclusion for UAS7 in those with both moderate to severe CSU. Thank you for your time, and I welcome any questions.
Appreciate it, Adam. Any questions from the committee? All right, thank you very much. So we'll get the recommendations back up. So the recommendations are to update the PA criteria for the TIMS for asthma and atopic dermatitis so that we can include the new recently approved TIMS and the expanded indications. Maintain nemolizumab and lebrikizumab as non-preferred. Revise the criteria to define that specific medical necessity appropriateness, and that provides that pathway through EPSDT. Remove the requirement for the co-prescribing of the EpiPens, and with the recent guidance change, update the trial, the oral immunosuppressants. And then we're going to look at the drug costs in executive session. But any discussion about the recommendations for PDL and PA criteria? Okay. Hearing none, we have a motion.
Approval.
Thank you, Doug.
Do we have a second?
Second.
Did you get that, Roger? I think that was Pat.
Thank you, Pat.
All right, all those in favor?
Aye.
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 Opposed? Abstain? All right, thanks everyone. Thanks Deanna and Dan. That was a ton of information, very well presented and organized, so we appreciate it.
That's a lot of information. Well, Deanna isn't off the hook yet. If you're following along the packet, we're going to stay with the TIMS. Draw your attention to page 164. And Deanna, if you've caught your breath, had a sip of water, back to you. Unless we scared you away.
Mute. All right. So now we're going to talk about the TIMS for autoimmune conditions. So if we can go to the next slide, please. So we're going to look at any new evidence for the TIMS that are used in RA, ankylosing spondylitis, plaque psoriasis, psoriatic arthritis, Crohn's disease, and ulcerative colitis. The last time the committee looked at this was last August, so we tend to look at these at least once a year. All the TIMS require PA to evaluate disease severity and to implement step therapy for common diagnoses. So the PDL status is in Appendix 3 in the packet. And then the frequently used outcomes for assessing disease improvement are in Appendix 2 of the packet. And then finally, the PA criteria is in Appendix 7. So since the last review last year, we have 7 systematic and 12 guidelines. So I will try to get through those without too much time invested in this topic. So if we could go to the next slide. Just wanted to highlight that we're looking at all of these drugs. So we have the biologic DMARDs versus the targeted synthetic DMARDs. So the biologics are typically parenteral molecules because they're larger. The biologic DMARDs are where we're seeing more of the biosimilar adoptions. So for the biologic DMARDs, we see biosimilars for adalimumab, etanercept, infliximab, natalizumab, rituximab, and ustekinumab. Then the targeted synthetic DMARDs are the smaller molecules, and those can be taken orally. So we're talking about the JAK inhibitors, the phosphodiesterase 4 inhibitors, the sphingosine 1 phosphate receptor modulators, and then the newest entry is the tyrosine kinase inhibitors. So some of the systematic reviews separated the biologic DMARDs from the targeted synthetic DMARDs, so that's why I took a minute to just kind of talk about that, the differences. So you can see there's a variety of approved indications for this class of drugs based on what their mechanism of action is. If we could go to the next slide, please. So the first systematic review that we looked at was a 2023 systematic review that looked at the therapeutic equivalence of biosimilars for adalimumab, etanercept, and infliximab compared to their reference biologic drugs. And basically, this systematic review showed that, based on moderate quality evidence, that the biosimilars are just as efficacious as the reference products. They were just looking at management of RA, so they were using the American College of Rheumatology criteria to assess those improvements. And then they also saw, based on moderate quality evidence, that the biosimilars result in no difference in safety outcomes, which included serious adverse events, drug discontinuation, and hypersensitivity compared to the reference products. However, they did see a little difference with the biosimilars in terms of the risks of treatment emergent adverse effects, injection site reactions, and the formation of anti-drug antibodies, which were lower with the biosimilars, but that was based on low quality evidence. All right, if we can go into the next slide. So I tried to organize this by disease state. So we'll talk about all the systematic reviews and guidelines for each disease state, starting with ankylosing spondylitis. So there was a 2022 systematic literature review that looked at the efficacy of the biologic DMARDs in ankylosing spondylitis. And so they showed this systematic review showed that the tumor necrosis factor, or TNF inhibitors, specifically golimumab and certolizumab, as well as the IL-17 inhibitors, so secukinumab, izokizumab, bimekizumab, and brodalumab, that those all improved symptoms of ankylosing spondylitis. These were all placebo-controlled trials. The efficacy of adalimumab and etanercept was shown in 2 randomized controlled trials, but those trials had an unclear risk of bias. Interestingly enough, when compared to placebo, the IL-23 and IL-12/23 inhibitors, so risankizumab and ustekinumab, did not show efficacy in treating radiographic axial spondyloarthritis. There was no new safety risks that were identified with the TNFIs in ankylosing spondylitis, and there was no new data for the IL-17 inhibitors. However, 3 observational studies did show, when they compared the TNFIs to IL-17s, that secukinumab and etanercept were associated with the increased risk of uveitis, which is a frequent comorbidity that is observed in patients with ankylosing spondylitis. If we could go to the next slide. So there was another systematic review that looked at the targeted synthetic DMARDs. So basically looking at the JAK inhibitors. I will point out that filgotinib, I'm probably mangling the name of that, but that is not FDA approved in the United States. It's approved in the EU, but it was included in all these systematic reviews. So they did show that the JAK inhibitors are efficacious in treating ankylosing spondylitis based on the 2 outcomes shown here on the slide. Interestingly enough, apremilast, the PDE4 inhibitor, was not effective in reducing the symptoms of radiographic axial spondyloarthritis. So the next slide talks about what the guidelines were that ASAS and EULAR released in 2022. So they basically recommend nonsteroidals as first-line treatment for ankylosing spondylitis. And then in terms of implementing a TIM, they recommend the TNFIs, the IL-17, or the JAK inhibitors if patients have persistently high disease activity despite conventional treatment. They do recommend starting with a TNFI or IL-17 over a JAK inhibitor, and that's because of the safety risks that have been observed with JAK inhibitors in patients with RA. However, if there's a history of recurrent uveitis or active inflammatory bowel disease, the preference should be given to a tumor necrosis factor. In patients that have significant psoriasis, the IL-17 inhibitors may be preferred because they seem to be more effective in improving skin conditions. We could go to the next slide. NICE did release guidance in 2023 for 2 drugs that are recommended to be used in ankylosing spondylitis. So tofacitinib and bimekizumab are recommended as options if they have not done well on a nonsteroidal, and only if they've tried a tumor necrosis factor and those haven't treated the condition. And then they added some guidance about what kind of response to therapy we should expect with these treatments. So a reduction in the ankylosing spondylitis disease activity and a reduction in the visual analog scale for spinal pain. If we could go to the next slide. So moving into rheumatoid arthritis. So there was a 2022 systematic review that focused on the efficacy of the biologic DMARDs and the targeted synthetic DMARDs. And that basically was the basis for the guidance that EULAR issued in 2022. So high quality randomized controlled trials showed that the JAK inhibitors combined with methotrexate or other conventional synthetic DMARDs improved RA symptoms based on the ACR20 response compared with placebo. This is the reason that filgotinib is not approved in the US yet, is because the studies haven't shown that it's been effective in RA. And then in a head-to-head comparison of upadacitinib compared to adalimumab, it showed that upadacitinib was more effective in achieving the ACR50 response. That was a low risk of bias randomized controlled trial. And then they also compared upadacitinib with abatacept, and that showed that they were that upadacitinib was superior in reducing the severity of the RA symptoms. And then there was a non-inferiority trial with filgotinib and adalimumab that showed that that it was non-inferior to adalimumab. We could go to the next slide. There was a second systematic review that looked at safety of the agents. And so this is where a lot of the evidence for the JAK inhibitors has come from, is from the RA trials. And it's a box warning for the JAK inhibitors in terms of the risk of malignancies and major adverse cardiovascular events. We see that more with the JAK inhibitors, specifically tofacitinib, compared to the other biologic DMARDs. However, the risk of serious infections is increased with the biologics compared with the conventional synthetic DMARDs, and it's similar across the biologics as well as tofacitinib. Of note, herpes zoster is more common with the JAK inhibitors than with the other DMARDs. And then lower intestinal perforations are rare, but they occur more often with tocilizumab than with the other biologics. If we could go to the next slide. So this is the EULAR guidance. A detailed summary is in the packet on table 3, I think in page 249, but I just highlighted basically that they recommend starting with a conventional synthetic DMARD, such as methotrexate, as soon as the diagnosis of RA is made. And then if treatment to target is not achieved, adding a biologic DMARD, considering JAKs is all right, but the risk factors for cardiovascular events and malignancy should be considered, and those risks are outlined in italics below. And then they do recommend that maintaining methotrexate in combination with either the biologic or targeted synthetic DMARDs. And then they have some guidance if patients cannot use methotrexate, that maybe an IL-6 inhibitor such as seralutinib or tocilizumab might be more effective, and that the targeted DMARDs may have some advantages compared to the other TIMs. We could go to the next slide. So moving into psoriatic arthritis. So there was a 2023 systematic review that supported the EULAR guidance for psoriatic arthritis. They do recommend all those biologics that I've outlined there on the slide because the evidence was very robust compared to placebo, that they were effective. In head-to-head trials of IL-17 inhibitors compared with the tumor necrosis factor, specifically adalimumab, it showed that they had a comparable ACR response rate, but as I mentioned, better skin response in patients that have that got the IL-17 inhibitors. And then there's a new targeted synthetic DMARD, deucravacitinib, which is a tyrosine kinase 2 inhibitor, and it's shown to be effective in RA, as well as the JAK inhibitor upadacitinib, and they were superior to placebo. There was one trial that looked at upadacitinib compared with adalimumab, and it did improve the ACR response, but there was more adverse events with upadacitinib. So more serious infections and herpes zosters rates were observed with the JAK inhibitor versus adalimumab, while there were similar rates of MACE and VTE. More fungal infections were observed with upadacitinib with IL-17 inhibitors compared to placebo and the other TNFi treatments. So if we look at the EULAR guidance on the next page, in patients with peripheral arthritis and an inadequate response to at least methotrexate or another conventional synthetic DMARD, starting with a biologic, either a TNFi, an IL-17, IL-23, or IL-12/23 should be started. And then they have some guidance about peripheral arthritis and an inadequate response, then perhaps a JAK inhibitor could be considered, taking into consideration the safety considerations that I've mentioned that we're seeing with rheumatoid arthritis. And then in patients that have mild disease, they're recommending a PDE4 inhibitor if they haven't responded to either a biologic DMARD or a JAK inhibitor. And then again, they're saying that the choice of action should look at, do they have more skin involvement? And in that case, perhaps preferring an IL-17 or 23 or IL-12/23. And then again, they have some guidance about patients that have uveitis, about preferring a TNFi in those patients. If they have inflammatory bowel disease, preferring a TNFi or an IL-23 or a JAK inhibitor. We could go to the next slide. So we do have specific drug guidance from Canada's drug agency as well as NICE. So Canada issued some guidance for bimekizumab to be used in combination with methotrexate to be used in patients that have active psoriatic arthritis. However, if they have psoriatic arthritis and a comorbid inflammatory bowel disease, severe uveitis, or an active infection, they do not recommend bimekizumab. And then bimekizumab is recommended by NICE if they have tried and failed 2 conventional DMARDs, including 1 biologic and a 1 TNFi. Next slide, please. So moving into plaque psoriasis, there was a 2022 systematic review that looked at the infection risks of TIMs when they're used to manage plaque psoriasis. And the IL-17 inhibitors are associated with an increased risk of Candida infections compared with placebo. In particular, secukinumab increased the risk of Candida. There was no difference between IL-17 inhibitors and TNFi, and there was no evidence that the TIMs increased the risk in serious infections in adults that had plaque psoriasis. And that was based on moderate quality evidence. If we could go to the next slide. So the Canada's drug agency, they do not recommend deucravacitinib for plaque psoriasis because they felt that the evidence from those 2 clinical trials was insufficient to determine that deucravacitinib offered treatment benefits over the currently available treatments that are available in Canada for people with moderate to severe plaque psoriasis in adults. We could go to the next slide. Now we're moving into ulcerative colitis. So in 2024, we got some guidance from the American Gastrological Association about what drugs to use in patients with moderate to severe UC. You can see those are outlined in the first bullet. And they do recommend in patients with moderate to severe UC using adalimumab, filgotinib, which again is not approved in the United States, or mirikizumab over no treatment. And then they had some guidance based on what they considered higher efficacy medications versus intermediate efficacy medications. The reason I bring that forward is when we look at drug costs and executive session, we would like to recommend some other drugs maybe to be preferred to use in patients that have UC based on the guidance that we got from the American Gastrological Association. If we could go to the next slide, please. So NICE and Canada's drug agency, they do recommend etrasimod as an option for moderately to severely active UC in people that are age 16 and over if they have not responded to other biologic treatments. And then they also had some recommendations for risankizumab only if a TNFi has not worked. And again, Canada's drug agency kind of mirrors the NICE guidance. They do recommend etrasimod, which is a sphingosine 1 phosphate receptor antagonist, if they've tried other TIMs in either the biologics or other JAK inhibitors. All right, if we can go to the next slide, looking at generalized pustular psoriasis. So there's only one drug that's approved for this particular indication, and that is spesolimab, which we have talked about before. It's indicated for the acute treatment of generalized pustular psoriasis flares and preventing the flares. And so we have guidance from the CDA about renewing spesolimab for preventing the flares, using that generalized pustular psoriasis global assessments. And then also NICE has some additional suggestions using it as an option for flares based on what the total score is and if there's fresh pustules and how much body surface area that it covers. So we tried to incorporate some of these guidelines in the PA criteria that we updated. Next slide, please. We also have guidance for hidradenitis suppurativa. So secukinumab is now approved for that. So we have guidance for the use of secukinumab, both from Canada's drug agency as well as NICE. And they do recommend it if adalimumab has not worked or if oral antibiotics have not been efficient. If we go on to the next slide. So systemic sclerosis is a rare connective tissue disorder, but we do have a couple of TIMs that are approved for this. And so I just outlined the guidance. Mostly tocilizumab is recommended. The table 1 on page 247 outlines the guidance for this. And then on the next slide, it talks about interleukin-1 autoinflammatory diseases, which are rare. I'm not going to talk about each one of these indications. The next slide kind of highlights the 3 IL-1 blockers, anakinra and rilonacept and canakinumab. We can go to that next slide. That's okay. This is the guidance, and it's specific for which kind of disease state they have. So these are rare, but we've got our PA criteria that support utilizing these drugs in these conditions. The next slide talks about screening and prophylaxis of infections for adults with autoimmune conditions. And our PA criteria mirrors this in terms of the screening for tuberculosis and making sure that they've been gotten the appropriate immunizations and prophylaxis for other diseases. Next slide, please. Okay, so we have some new formulations. There's 8 new biosimilar products that have been approved in the last 2 years for Stelara or ustekinumab. There's a biosimilar that was approved for tocilizumab, and it has FDA approval for treatment of adults with RA, giant cell arteritis, or COVID. And then there's a new auto-injector device for mirikizumab, which was approved earlier this year. In terms of expanded indications, those are on the next slide. So apremilast is now approved for pediatric patients 6 years of age and older for psoriatic arthritis. Adalimumab, the biosimilar, is approved for adults with uveitis. Tremfya or guselkumab is now approved for adults with moderately to severe active UC and CD. And just this week, they got the approval to treat children 6 years and older with psoriatic arthritis and plaque psoriasis. Cimzia it has an expanded indication for polyarticular JIA in patients aged 2 years and older. And then bimekizumab has an approval for adults with active psoriatic arthritis, ankylosing spondylitis, and HS. And then mirikizumab is now approved for adults with active CD. So if we go to our recommendations, our suggestion is to modify the TIMS PA criteria to include the expanded indications for those recent FDA approvals that were outlined in the conclusions, and then to update the TIMS PA criteria with the recommendations from published guidelines. And then, as I mentioned, we'd like to review drug costs in executive session and evaluate higher efficacy treatments for ulcerative colitis to determine if one agent should be preferred along with adalimumab. And those choices are listed there on the slide based on the AGA 2024 guidance. So if we go into the changes to the PA criteria, which starts on page 288 of the packet, first was table 1, just updating the TIMS for ankylosing spondylitis, juvenile idiopathic arthritis, RA, and ankylosing spondylitis with the expanded indications for bimekizumab and Cimzia. The next slide is the plaque psoriasis, psoriatic arthritis, and HS expanded indications. So we see that apremilast or Otezla is now approved for psoriatic arthritis. Bimekizumab has expanded indications, as does Tremfya, which was just released this week. The next slide talks about the changes for UC and CD. So again, guselkumab or Tremfya is approved now for Crohn's disease and ulcerative colitis, as is mirikizumab. We go on to the next slide. We updated table 4. So upadacitinib now has the approval for GCA. So table 4 is the catch-all for all the other diagnoses that are covered in those other tables. If we could go to the next slide. So we updated the first-line conventional therapy based on the guidelines in terms of what the recommendations are for ankylosing spondylitis as well as HS. And so you can see those updates there. The next slide is a new table. So we, instead of having a bunch of questions that asked about baseline assessment for these therapies, we like to put tables together because it makes it a little bit easier for Gainwell to do their assessments. So we added this table, which is baseline documentation of disease severity for selected conditions. So we just did it for ankylosing spondylitis, atopic dermatitis, or plaque psoriasis, generalized pustular psoriasis. As I remember, there's only one drug that's approved for that, and then HS. So if we go to the next slide, this is just a summary of how we changed the questions. So we added question 4 to ask if baseline severity has been documented for those conditions that are outlined in table 7 based on the recent guideline recommendations. We modified question 6 to ask if TB screening was completed at baseline instead of annually. We were getting a lot of reconsiderations that was looking for the TB screening annually. So we just decided to do it at baseline. And then we removed the question that about using upadacitinib for AD, since that was addressed in question 5 with the tables with atopic dermatitis included in those tables. And then the next slide talks about how we revise the renewal criteria. So we revised question 1 to ask if the patient's symptoms have improved with therapy according to those outcomes that were developed in table 7. And then we didn't make any changes to the adherence assessment or the provider attestation that the patient's condition has improved with therapy. So we tried to develop all those changes in the PA guidance based on the guidelines that I went through. I know I went through a lot in a short period of time. Are there any questions from the P&T committee about those changes?
A lot of information. Again, as I mentioned at the top of the order, we adjusted the packet. So if you're looking for the criteria in the posted packet, it's on page 228.
Okay, I'm sorry, I had the wrong packet. that I
No,
was
I had the
looking
wrong
at.
one too. It keeps bouncing around. So
Okay. And we do have public comment, right?
we do. We have 2 representatives in industry. First, we have Rochelle Yang with Tiva. Are you able to unmute your line?
Yep, I am.
Fantastic. The floor is yours when you're ready.
All right, thank you. My name is Rochelle from Teva. Just wanted to share some quick information around Solarsdi or Istokinumab AEKN, which is a biosimilar to Stelara. It was approved a year ago and launched in February of this year, and it's available on the market as 45 milligram prefilled syringe, 90 milligram prefilled syringe, as well as the vial for IV induction dosing. And it is also approved as interchangeable with Stelara. Biosimilars as a whole have driven competition and have contributed to significant savings for the healthcare system. Currently, neither Stelara nor its biosimilars are on the Oregon Medicaid PDL, and we do hope the launches of these biosimilars will help reduce the cost and allow Istokinumab products, including Solarsdi, to be more accessible for patients on the PDL. Thank you.
Talking on mute. Thank you. Any questions for Rochelle? All right, and we also have Shannon DeBartolo. Give me 1 second here. Shannon, are you able to unmute your line?
Hello, yes, I am.
All right, the floor is yours. Actually, let me first preface that for the committee. You're a representative from with Amgen, so just so the committee is aware. All right, the floor is yours.
All right, thank you very much. Good afternoon. My name is Shannon DeBartolo, and I am a medical value and access liaison with Amgen Scientific Affairs. I'm here today to provide testimony on Otezla in support of Amgen's request that the committee continue to maintain preferred status for Otezla covering the product to label. Otezla is the first and only FDA-approved oral therapy for adults with all severities of plaque psoriasis who are candidates for phototherapy or systemic therapy, and for the treatment of adults with active psoriatic arthritis. In pediatric patients ages 6 and over weighing at least 20 kilograms, Otezla is approved for the treatment of moderate to severe plaque psoriasis. And most recently, on July the 23rd of this year, Otezla also received FDA approval for the treatment of active psoriatic arthritis in this pediatric population. And thank you very much for recognizing that most recent approval during the presentation. Lastly, Otezla is also the only FDA-approved product for the treatment of adult patients with oral ulcers associated with Behçet's disease. The 2020 Joint American Academy of Dermatology National Psoriasis Foundation guidelines for the management of psoriasis with systemic non-biologic therapies recommends Otezla for the treatment of moderate to severe psoriasis in adults. The guidelines also state that overall Otezla as a monotherapy is beneficial to treat plaque psoriasis as well as psoriatic arthritis. The 2021 GRAPPA guidelines strongly recommend Otezla as a treatment option for psoriatic arthritis patients with DMARD-naive peripheral arthritis, enthesitis, dactylitis, plaque psoriasis, and nail psoriasis. Otezla is an oral tablet administered twice daily and is not a biologic. It does not require lab monitoring, and its most common adverse reactions are diarrhea, nausea, and headache. Based on the information provided, I respectfully request the committee continue to offer Otezla as a preferred oral treatment option with coverage aligned to its label. Thank you very much for your time.
Thank you, Shannon. Any questions from the committee for Shannon? All right, we have a late breaking request. Rick Melby just asked to provide public comment. Rick, are you able to unmute your line?
Yes, I am. Can you hear me?
Yeah, please introduce yourself for the committee, and you have 3 minutes.
Sure will. Thanks, Roger. Good afternoon. I'm Rick Melby. I'm a PharmD with UCB, and I'd like to update you on important clinical information on bimekizumab, or brand name Bimzelx. Bimzelx is the only humanized IL-17A and IL-17F antagonist indicated for the treatment of adult patients with plaque psoriasis, active PSA, active non-radiographic axSpA, active AS, and moderate to severe hidradenitis suppurativa. So let's look at Bimzelx efficacy data. First in PSO, just kind of a reminder, in the PSO clinical program consisting of 4 clinical trials, Bimzelx did achieve superiority versus all active comparators and placebo. In phase 3b studies, treatment with Bimzelx produced rapid, complete, and durable responses with PASI 90 results significantly improved and superior versus placebo, Humira, and Stelara at week 16, which was the primary endpoint. PASI 100, or complete skin clearing results, were significantly improved and superior versus placebo and versus Cosentyx at week 16, which was the primary endpoint. Long-term open label data out to 3 years showed responses were maintained regardless of baseline demographics, disease characteristics, or prior exposure to biologics. In PSA phase 3 studies, treatment with Bimzelx produced rapid and sustained responses. ACR 50 responses were the primary endpoint at week 16 and were significantly improved versus placebo in both DMARD naive and TNF alpha inhibitor inadequate responder subjects. In the NR non-radiographic axSpA and AS trials, phase 3 studies, Bimzelx produced rapid, deep, and maintained responses. ASAS 40 responses, the primary endpoint at week 16, were significantly improved in both subjects with NR axSpA and AS versus placebo. And finally, in HS, in phase 3 studies, treatment with Bimzelx produced rapid, sustained, and maintained responses. HiSCR 50 responses, the primary endpoint at week 16, were significantly improved with Bimzelx 20 milligram every 2 weeks versus placebo. And patients treated with Bimzelx had rapid responses compared to placebo as early as week 4. As far as safety information, there are no contraindications, there are no box warnings or REMS programs. And the most common AEs were upper respiratory tract infection, oral candidiasis, and headache. And lastly, Bimzelx is available as a pre-filled syringe and auto-injector for self-injection or administration by a healthcare professional. And our ask today is to respectfully request Bimzelx be placed in a non-preferred single-step addition position on your PDL. And again, thank you for the allowing me to break in here late in the game, but appreciate your time. I'll take questions if you have any.
Thanks, Rick. Any questions from the committee for Rick? Okay. We also have a request from Aaron Nowak with AbbVie. Aaron, are you able to unmute your line?
Yes, can you hear me?
Yep, hear you loud and clear, and the floor is yours.
Okay, thank you. My name is Aaron Novak, Medical Outcomes Science Liaison with Medical Affairs at AbbVie. Thanks for a few minutes to provide information on 2 products, upadacitinib or Rinvoq and risankizumab or Scaredy. I'm providing information on these 2 therapies to support the request of the committee to add Rinvoq and Scaredy to the Tier 2 preferred drug list in a label appropriate manner. Per label, Rinvoq is approved following 1 or more TNF blockers for all indications, except atopic dermatitis, where it's approved following other systemic drug products and rheumatoid arthritis. In the targeted immunomodulator space, there are many therapies and a lot of different mechanisms, but there still continues to be a significant unmet need, with up to 60% of patients failing to achieve treatment goals that are set by guidelines, leaving patients with significant morbidity and disease burden. Rinvoq, which is an oral JAK inhibitor, now has 9 indications with clinically meaningful attributes, including number 1, rapid onset of action and durable response. 2, it's the only JAK inhibitor with the Crohn's disease indication. 3, there's the ability to achieve rigorous treatment targets that are set by guidelines, such as endoscopic remission and steroid-free clinical remission in IBD and clinical remission in RA. And then 4th, there are 6 head-to-head trials versus 4 other mechanisms for Rinvoq, showcasing an improvement in patient care, and also these data help inform treatment decisions. Given these clinical attributes and Rinvoq being FDA approved for most indications after patients had already failed a TNF blocker, the request of the state would be to consider moving Rinvoq from tier 3 to tier 2 preferred second-line access in PDL. And then next, for Skyrizi, there are 4 approved indications here: moderate to severe plaque psoriasis, psoriatic arthritis, ulcerative colitis, and Crohn's disease. Meaningful clinical attributes of Skyrizi are durability of response, ability to achieve those rigorous treatment targets as well. And then there are 6 head-to-head trials of these 4 different mechanisms for Skyrizi. Both therapies have a favorable benefit risk profile. More information on safety can always be found in prescribing information at rxappy.com. And in summary, with the clinical attributes of these therapies, there would be treatment options that would be beneficial for Oregonians with autoimmune conditions, as well as for the state. And I just want to close by respectfully requesting that Skyrizi and Rinvoq be considered for tier 2 preferred drug list for all indications. Thanks for your time and for working me in here, and I'd be happy to answer the questions that you have.
You bet. Sorry if I missed you previously, but thanks for entertaining the committee. And any questions from the committee for Aaron? Okay. With that, we'll put the recommendations back up on the screen.
Just a quick comment.
Yeah, Pat.
Just curious on that table 7 for like responsive therapy and renewal criteria. Deanna, I'm guessing that like all of those thresholds for like ankylosing spondylitis or HS, like, you know, that like 50% reduction in abscesses, like presumably those are like pre-specified trial criteria, like thresholds, or come from somewhere.
Guidelines. They come from the guidelines.
Amazing. Just figured they weren't arbitrary. That sounds great.
Right. Good question.
So the recommendations in front of the committee: modify the TIMS PA criteria to include the expanded indications and recent FDA approvals. Update the criteria of the recent recommendations from published guidelines. And we're going to review the cost in executive session. Anything else you want to add, Deanna? No?
No.
It's all here. Plenty. All right. Any
I move
discussion?
for approval of the recommendations.
Thank you, Doug.
Do we have a second?
This
Second.
is Jeannie. I'll second.
Great, thank you. All right, all those in favor?
Aye.
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 Anyone opposed? Abstain? All right, thank you. And again, thank you, Deanna. You always make this so much easier to understand, so I appreciate it.
I think I
Right.
mangled some of the drug pronunciation, so I apologize for that.
Oh, way better job than I would have done, so.
Did a fantastic job. Well, we're right back on schedule. We're going to take a 10-minute break. So I am going to start the timer, and we'll get on with the rest of the agenda in 10 minutes. So thank you all. All right, we're coming back from break. Recording is back on. And moving on the agenda, if you're following along in the packet of materials that's been posted, we are going to do the Omnipod evaluation. It starts on page 240, and we're going to turn it over to Kathy Centena.
Great, thanks, Roger. The purpose of this review is to evaluate the tubeless insulin pump Omnipod. A criteria will be developed to allow for use when medically necessary. We'll go over that in more detail later. So the Omnipod was originally approved in 2003, and then later the Omnipod Dash, and then subsequently the Omnipod 5, which we'll refer to as OP5, was approved in 2022. The OP5 is the only insulin delivery system that is currently tubeless and approved by the FDA. However, there are other similar systems with automated insulin delivery, which we'll talk a little bit more about that later, that are available. Most insulin pumps are available through the Durable Medical Equipment, the DME benefit, for members who meet medical appropriateness criteria as outlined in the Oregon Administrative Rule. I did include that in the packet, and it's available on page 259 if you want all those details. The OP5 system is only available through the pharmacy benefit, and coverage requires documentation for why a less costly insulin delivery device is medically inappropriate. So we're going to go over some background since this is new territory with a medical device. I'm just going to give you some hopefully helpful background information. First of all, we're just going to talk about the difference between the tube pumps and the tubeless pumps. The tube pumps, they're small devices, of course, that have the tubing attachment, which most of you are probably familiar with. These devices do hold 200 to 300 units of insulin, and they are hybrid closed loop compatible or HCl compatible, which we'll talk about in just a moment. The tubeless pump, which currently we're talking about the OP5, of course, it's a pod worn on the skin and has wireless control. It holds a little bit less insulin, up to 200 units, and it is also HCl capable. It doesn't have the tubing, so there's no risk of tangling, and it's more discreet as well as it is waterproof. I want to give you just a little bit more information on pumps. Looking at the next slide, like I mentioned, you'll hear me talk about automated insulin delivery, or AID. And this is just kind of an umbrella term for an insulin pump that's connected to a continuous glucose monitor that is also controlled by a computer algorithm to automatically adjust the insulin delivery in real time. So both these closed loop systems and the hybrid closed loop system, or HCl, utilize this technology. Now, there are some differences. The closed loop system, as you can see there, the CGM talks to the algorithm, which then tells the insulin pump how much insulin to deliver. These closed loop pumps do not require any kind of adjustment for meals, exercise, illness, or sleep, and are often referred to as the artificial pancreas. Currently, there are no FDA-approved closed loop systems. The HCl is very similar, as you can see. However, it does still require input for meals or other situations which would require extra insulin to be announced by the patient to manage glucose closely. So then moving on to the next slide, looking at these different systems in general, and we're not talking just about the Omnipod here, but they have shown that these HCl systems help to decrease HbA1c and increase target blood glucose ranges, which is considered 70 to 180 milligrams per deciliter. Evidence has also shown a reduced risk of hypoglycemia with these systems. Specifically, a study done in patients that weren't at goal glucose levels, that adding the AID system helped to bring glucose into range about 60 to 64% of time. Additional evidence suggests even a higher percent of time in range, anywhere from 68 to 75% of time. So for devices, since they are slightly different than drugs, actually dramatically different as far as the approval pathway, we'll go over that just briefly. So the medical devices are classified as 1, 2, 3, far as the potential risk to the patient and level of regulatory control needed to ensure the safety and effectiveness of the medical device. So most insulin pumps are classified as a class 2 device. However, the insulin pumps with the AID technology are classified as class 3. Now, all the different Omnipod iterations were approved through the 510(k) pathway, which is that middle row there. And they just had to show that the device was similar to comparative items already on the market. So other insulin pumps, they refer to these as a predicate device. So this pathway does not require submission of clinical trial data. However, here in just a moment, we are going to talk about some studies that have been done with the Omnipod. So let's talk more specifically about the Omnipod. So the OP5 AID, it's approved for the management of type 1 diabetes in patients 2 years of age and older, as well as type 2 diabetes patients that are 18 and older. It does have that pod that contains the insulin that attaches directly to the skin without any tubes, and the ability to deliver insulin up to 3 days. The system holds anywhere from 85 to, that should say 200 units of U100 rapid acting insulin, and it is compatible with Novolog, Humalog, and Ademolog. That AID algorithm, as I was talking about, it's a software program that automatically adjusts the insulin delivery through the pod in response to those CGM values. This system does integrate with the Dexcom G6, Dexcom G7, and the Freestyle Libre 2 Plus as the CGM systems. And it does this about every 5 minutes if needed, and it's operating in the automatic mode to adjust insulin needs based on those CGM values. The system does rely on either a smartphone using the iOS or Android platform, although it does have the ability to operate under a dedicated OP5 controller if the patient prefers not to use a smartphone. So we're going to look at 5 efficacy studies that evaluated the OP5 system. The evidence in general is of low quality, but it does show that it improves HbA1c and the time, increases the time in target blood glucose ranges. The evidence for the OP5 system was from low quality studies, primarily because they were based on single arm, open label, non-controlled trials in patients with type 1 and type 2 diabetes. In fact, 3 of these studies are single arm, and they just compared the OP5 to baseline measurement, so the changes based on comparisons to baseline. And then 2 studies did look at comparison of two different phases or systems, but they just were evaluating the AID feature versus versus operating the system in manual mode. So there's no high quality evidence on comparative effectiveness or safety of the OP5 versus other insulin pump systems. But let's look at the studies that we have. The first one, it was a multi-center single-arm outpatient study of 241 patients that included children and adults. Most of these patients had been previous CGM or previous pump users. The inclusion criteria was just type 1 diabetes. And as you'll see in most of the studies that looked that were used in type 1 patients, the exclusionary criteria was a history of severe hypoglycemia or diabetic ketoacidosis in the previous 6 months. So in this study, there were 2 co-primary endpoints. The Omnipod 5, like I mentioned, was compared to baseline values. So in children, the use of the AID OP5 system did help to reduce HbA1c by 0.65%, and then in adults by 0.3%. And as we know, the MCID, or the minimal clinically important change for HbA1c, ranges from 0.3 to 0.5. 0.3 because it decreases microvascular complications, anything by a decrease of 0.3 or more. And then FDA and guidelines usually go by a 0.5 decrease as being clinically significant. But in either case, both of these were close to that or met or exceeded that. And then if we look at time in range, we see that children increase their time in range by 15% and adults by 7.9%. And the clinically significant value in this is around 5%. So both groups meeting that criteria as well. And these tables are discussed further in your packet starting on page 249 if you want to look at the tables in more detail. So the next trial here is in type 2 patients. Again, multi-center, single-arm, non-inferiority outpatient trial of 305 patients. Mean age quite a bit older, 57 years, as it would be expected in type 2 patients. These patients were also using GLPs, 55% of patients, and 44% using SGLT2s. And a majority, 73%, were using multiple daily injections. Major inclusion criteria, just type 2 diabetes with HbA1c less than 12 or 7% or less for those using only basal insulin. They could not be familiar or using an AID, or excuse me, they just could not be using an AID system previously to be enrolled in the trial. The primary outcome for this study was, again, a comparison to baseline values, a change in HbA1c at 13 weeks. And you can see that HbA1c was decreased by 0.8, so meeting that clinically important threshold. And then the secondary endpoint of time in range for glucose values, that was also increased to 20%, which would be statistically and clinically significant. So the next study is a real small study, actually a multi-center single arm study that looked at type 1 patients and looked again at their time in range. It was a co-primary endpoint compared to either one operating the device in manual mode versus operating the device with that AID feature. And it did show that there was a decrease in low or hypoglycemic readings, less than 70 milligrams per deciliter with the use of the AID system. However, it did not show a statistical or clinical benefit in those hyperglycemic ranges above 180. The next study, again, comparing just the AID versus manual mode use of the insulin pump, but this was a larger study, 194 patients of type 1 diabetics, mean age of 36 years. Previously, most of them did use a CGM. This trial was interesting because they had to have been using the insulin pump for at least 3 months, so they had to be familiar with that. And then 50% actually had to be using the Omnipod pump. So that's something that was not included in other studies. And so if we look again at the primary outcome, it was the number of patients in target ranges there compared to baseline, and they did, or manual use, I guess, rather, and they did find that the use of the AID system did improve time in range by 17.5%. And then that change in HbA1c was also statistically significant as well, with a decrease of 5% in those that were using the AID system. And then the last study was done in pediatric patients. So this was a study of 80 patients that were ages 2.5 to 9 years of age, mean age of 4.7, that also were familiar with using the CGM and insulin pump, with a majority of them having done so. And this one also looked at the co-primary outcomes of change in HbA1c at 13 weeks compared to those baseline values like we talked about. And that did show that it was effective in this population with a decrease in HbA1c of 0.55%, and then also improved time in range, but not to the extent that we saw in the other studies. And it was not quite clinically significant, with only a difference of 5% between baseline and then follow-up. So safety information, they're mostly looking at hypoglycemia and DKA. In one study, they did find that the incidence of severe hypoglycemia was low in patients that use the AID system, with 3.6 events per 100 person years in children, and then 6 events per 100 person years in adults. In a study of just adult type 1 patients, they did find that there was one case of severe hypoglycemia, and that was in the control group, but there were none in the AID group. However, these numbers are so small, it's hard to say if it's clinically significant or not. And then the same thing with DKA, there's really insufficient evidence to determine if the AID system or the OP5 system decreases the risk of DKA. Hypoglycemia events were also reduced in adults using the system, and by about 0.9% in adults. And again, so not a huge difference. And then children, there wasn't much difference in those hypoglycemia rates reported in another study. And then in type 2 diabetes patients, we saw the same thing, not much of a difference between standard or manual care. And then one study did report a reduction in the hyperglycemia events in patients with type 1 by about 24% in adults and 33% in children with the use of the OP5 system. So what are some of the clinical implications or practical implications of the device? So not all the studies reported on device issues, but a few of them did. So I'll report those to you here. In adult patients with type 1 diabetes, one study did find that device issues occurred in 30 participants in the intervention group compared to just 6 participants in the control group. Another study of children and adults found that there's approximately one device deficiency per person month of system use, which most of the issues were related to the pod. So people relate things such as the pod falling off and connectivity issues, as well as there was actually a recall because of a communication issue with the Freestyle Libre CGM device that has been resolved. But there have been some technical issues there. Additionally, some users report leakage around the cannula, and then poor customer service and inadequate response and issues with supply replacements. So what I want to do now is go over the recommended PA criteria. The goal of this is really to provide some utilization parameters for the Omnipod tubeless pump in patients that require this management and which other insulin pump alternatives do not meet the patient's needs. So what we're going to do is just go through it briefly. And I do want to highlight a couple of changes that we made since the final posting, and you'll see those there highlighted in yellow, and they're only a couple, and it's just kind of to clarify the criteria. So at number 1, we ask for the diagnosis and if the patient has type 1 diabetes, and then we ask if it's renewal criteria. And then if the patient has been on an external insulin pump prior to their enrollment in fee-for-service, then we're asking them to go to number 7. For all those new users, we're asking for them to satisfy their criteria again that's guided by the DME benefit that's already available. And so we ask that they'd completed a comprehensive diabetes education program. They use multiple daily injections of insulin, at least 3 per day, with frequent self-adjustments of insulin doses for at least 6 months prior to insulin pump use. And then the frequency of glucose testing on an average of 4 times daily during the 2 months prior to the initiation of the insulin pump. And if so, then we also ask that they meet at least one of these following criteria: that they have an HbA1c over 7, a history of reoccurring hypoglycemia, wide fluctuations of blood glucoses before meal times. They experience the dawn phenomena with fasting blood sugars frequently exceeding 200 milligrams per deciliter, or a history of severe glycemic excursions. If yes, then the final criteria is, does the patient have an extenuating circumstance? So do they have difficulty operating an insulin pump with tubes? Do they have routine involvement in an activity that requires the device to be waterproof? And additionally, that does not allow the use of tubed or tethered. We added that insulin pumps. So why they can't use the other options. If so, approve that for up to 12 months, not exceeding 11 pods in 1 month. And then to document that extenuating circumstance and or the reason why the current pump is medically inappropriate. And then for renewal criteria, we ask that, of course, that if they've been previously approved for the Omnipod pump, and if they have they seen and been evaluated by their practitioner for at least every 3 months, and then there's documentation that the HbA1c targets are at goal levels, and if so, then again that approval of 12 months not exceeding 11 pods in 1 month. So the recommendation overall is to designate the OP5 as a non-preferred pump with prior authorization criteria required for use. I'm happy to take any questions or comments.
Nice job, Kathy. Questions for Kathy? No public comment, so.
Hey, this is Russ. So I had two questions. One is, the Omnipod is also approved for type 2 diabetes. Do we not need to have a pathway to coverage for DME?
It's currently not covered through the DME benefit, so we just aligned our criteria with that, and that's their criteria for all insulin pumps.
Okay.
Yeah, so that's kind of why we modeled it out. I mean, that's a great question because we certainly would not want to consider that, but that's why it was written this way.
Yeah. And then in the renewal criteria, it asks if there's documentation that the patient's A1C targets are at goal levels.
Mhm.
I think, I mean, nationally, what is it? 25% of type 1 diabetics have an A1C under 7. So, I mean, that might be excluding a lot of people who would still benefit from having an insulin pump. So, I mean, I'm thinking maybe we could just, change that to like, improvement in A1C. I mean, I don't know what the rest of the committee would feel comfortable with. I just think that that is a fairly high bar.
Well, we specifically didn't put a number in there, hoping that it would be more provider patient specific. But if that seems confusing, then we could definitely change the wording. I'm looking
So what-
back. I think that's how it was worded in the other criteria.
So, I mean, because, yeah, I mean, I took that to mean, like,
At goal.
yeah, that, well,
Yeah.
yeah, that, that the goal level, like from an OHA standpoint, right, is less than 7. So if the provider can set their own goal, then yeah, so
I think that's a valuable point, though. It should be more clear, because if you took it as that, then other providers will probably take it as that as well. And I agree with you. I think that it shouldn't be at goal, like you're saying, less than 7%. So maybe documentation of HbA1c improvement or improvement or maintenance of.
I mean, yeah, I mean, I guess I'm like clinically significant improvement, right? I mean, or
maybe if like, is the patient compliant with the treatment plan?
Or this might be heretical, but just like omit that number 3.
That's what
You
I
know,
was
to-
gonna say. I agree.
Okay, omit number 3.
Improved as a result of the pump.
But
I
even
mean,
if it's not, are we gonna say you can't use it? I mean, if it's not improved, doesn't mean that that's not working. Maybe it means that they're not doing the treatment, but are you gonna take that away? I mean, it's.
Yeah.
There's so many reasons it might not be
Yeah,
improving.
exactly.
Yeah, absolutely. I mean, I like, is the patient compliant with the treatment plan? Right? Because, I mean, that can be, right, collaboration between the provider and the patient to create their own treatment plan, but that wouldn't necessarily, negatively impact a patient if they were following the treatment plan, but their A1C wasn't improving. Right? I mean, that maybe seems like a lot of responsibility for the patient. Right? And so, I mean, if this is part of a larger process of improving their diabetes control, versus, right, like if a patient is, not following up, every couple of years and, not refilling their insulin, right? Like that would be a very different scenario.
Yeah, agreed. I think that could be an appropriate substitution if we keep it. I like that wording as well.
So the guidelines for CGMs is that there's documentation that it's actually being used. At least 50% of the time. With a insulin pump, it's I'm not sure that there's a percentage, but I mean, obviously, if someone isn't compliant with it, then I think we're done. So I would want to, for renewal criteria, to demonstrate that there's compliance.
And let's see, maybe is patient, yeah. Yeah, so I think so are you okay with the wording that is the patient compliant with the treatment plan, or would you want more specific documentation of compliance?
No, I think that would be fine.
That would be okay, okay.
Does anyone know the percentage of patients with type 1 diabetes who use greater than 66 units of insulin per day?
It's a really good question. And I mean, like,
right, 200 milliliters, or right, the 11 pods per month, right? That's assuming that the pod lasts the full 3 days. Which
I would be concerned that might not be enough for at least some of my patients.
Yeah, I mean, that's kind of when I go back and forth, right? Like, I think that there'll have to be some sort of an allowance if they're exceeding that amount, right? We would have to have some conversation with the provider doing the PA, during the PA process about how many units per day they're using, I think.
Could that be a separate question? So it's just, I'm just worried about the back and forth of this as a provider having to do the process and being like, oh, it's approved, but not actually for as much as you need.
Sorry, this is Jeannie. I can't tell who the kind of like, I don't remember the specialties of everybody, but is it worthwhile, or did you guys already have an endocrinologist who, does a lot of type 1 diabetes with these pumps already? Did we have somebody look at that or get that perspective already?
We have not with this criteria. So this criteria mirrors very closely what is currently implemented in our OARs for other insulin pumps. But it is something that the OHA is working on. I know, and I don't know the specific timeline, but the HERC is taking up this topic of tubeless insulin pumps as well. And so that is part of their process, I know.
Yeah, that's usually, I love that part of the process of the HERC, because as I work with specialists, I'm family medicine, but as I work with specialists who bring up new data or new ideas, I'm always, putting them in touch with the HERC folks and saying, hey, let's do this, give them some new information, whatever you have for the review. And I guess I just think about that in this perspective, like the folks most using this, what is their perspective on an appropriate criteria there?
I do a lot of management of type 2 diabetics and with insulin, and so I can at least speak to that. And I would be concerned about the back and forth of limiting the pods and then having to then re-auth something that was partially authed. It's just like the barrier to care and the level of administrative work that requires as a provider, having to go and just to essentially redo the process or have to like do a peer-to-peer is a lot.
Agreed. I agree with you.
As many patients as would need it.
Would that happen though? I think that once the PA is approved in the system, though I'm not saying we don't want to address this, but I think once the PA is approved, as long as the day supply that the pharmacy is, or whoever's filling it is submitting, it's not like it would only would it be able to go through more than once a month if there was some different change to the insulin and then maybe it get addressed after the fact? Does that make sense? Like, you know, if the 11 pods ended up lasting 23 days for that month because of a dose adjustment during the month, they would still be able to refill the medication and stay on the therapy, correct?
I'm just thinking of the patients. I can think of at least 10 patients right now whose just baseline prescription would exceed this.
Oh, yes, 100%.
And that's what I'm worried about.
Yeah. So Kathy, would it be reasonable to ask about the like average number of units a day or something like that, and then adjust the number of pods based on that?
Well, I that's a great thought. However, as we know, I mean, those needs can change. And so then again, talking about the PA burden for the providers, I'm not sure the best way to go about it. Perhaps we could do,
May I?
Yeah.
I think if there was just like one additional question, if we thought it was going to exceed that in a month, if you could just have a one-liner explaining your rationale as a clinician, and if your attestation was enough, that would not be that much work. I would be able to get it done just in the moment. I think that would feel good for a lot of the providers that do have to do this, just to be able to explain why somebody needs more at the time and be done.
These are prescribed like medication, right? So, I mean, the pharmacy calculates, right? If I send in a prescription that says, take one a day, but my quantity is 15, right? They contact me and they say, hey, this is not enough. Right. Similarly with these, right? If you say, the patient takes, 70 units of insulin per day, right? Then, you can calculate exactly how many pumps that they need. And it seems like that part, like in terms of the number of pumps that they will need, is kind of potentially part of the prescription. I mean, obviously the insulin would be prescribed separately. So maybe not, but I mean, it seems like if you knew how much insulin that they were currently taking, you would know exactly how many pods they needed.
True. So you're saying leave it up to the provider then just to write for the correct amount of pods and don't necessarily have a stipulation in the criteria regarding that?
That might be the easiest.
Yeah, I mean, I think the 11 pods per month, has a pretty, would likely limit a bunch of people. I mean, the average range for starting a person on a type 1 diabetic on insulin is 1/2 to 1 unit per kilogram of body weight as a rough estimate. So it would not take a very heavy patient to so yeah, I mean, I think I appreciate the concept of the limit and the being mindful of the cost of these devices because they are extremely expensive. I just think that it's going to take a lot of work for providers to be constantly asking for an exception for this. So yeah, I think just removing the quantity of pods, unless there's a better way of tracking, matching their pod prescription with their insulin prescription somehow.
I think
that's very
good, because if you're doing a dose escalation, trying to get them closer to their target because they now have been doing the pump for longer, you're going to run into issues of having just off this amount and then needing more. And so if it could not be specified, I think that would probably be the most useful.
I think that's more than reasonable, and perhaps we could even take a look at this, down the road and see what the usage is and see if it's appropriate, based on patients and estimated needs. Again, it's hard with not real-time data on charts and things like that, but I think that'd be reasonable to take out the pod restriction.
Makes sense.
Yeah.
Evaluate, do a policy evaluation and look at the use. And if there seems to be inappropriate use, then revisit it. Otherwise, yeah, get out of the way.
And theoretically, this would be limited to a 30-day supply on the claims anyway, right? This isn't one that would go through for 90. So we would know that number of pods, should be lasting 30 days. And if we're seeing that it's either being refilled more frequently or whatever, then we could address it. Or if somebody's getting 300 pods a month, then obviously that's going to be something we would want to make sure and look at.
Agreed. Yeah.
This is Eddie. I'm sorry, I was having some connection issues earlier, so I don't know if this was addressed yet, but why does that number 2 under renewal for yes lead to a denial?
Oops, you're right. Those should be switched. Sorry. Yes, thank you.
Okay, just making sure I was
Thank you
understanding
for
that
catching
correctly.
that. Yeah, appreciate that.
Other comments or thoughts? A lot of great feedback. Thanks for reading the numbers and being astute and fighting the connectivity issues, Eddie.
Yeah, that's it for me. I mean, as long as we take the pod number out of both the PA and the renewal criteria.
Of course, yes.
No.
All right, so then the recommendation is to designate it as non-preferred with PA as amended.
To approve.
Thank you, Russ.
Second.
Thanks, Samara. Appreciate it, Sam.
All right, all those in favor?
Aye. Aye. Aye.
Opposed?
Aye.
Anyone abstain? All right, thank you.
All right. Turn your attention to page 263 if you're following along in the packet, and we'll turn it over to Sarah Fletcher. Sarah, you might be on mute.
I was definitely talking on mute.
All right.
Thanks, Roger. The next topic up is the continuous glucose monitoring systems, or CGMs, to follow up Omnipod, so another non-drug item. The purpose of this class update was to compare the efficacy, harms, and other differences between the CGM products for patients with type 1, type 2, or gestational diabetes. You can go to the next slide. Just for some background, in contrast with finger stick glucose monitoring, CGMs are devices that have an interchangeable sensor and can be inserted and left in the skin, often for weeks. There are some that are implantable and last for months, but we don't get those through the pharmacy benefit, so we're not talking about those. They measure interstitial glucose, which can lag behind blood glucose by about 5 to 10 minutes, and they transmit the readings to a receiver, which is often for many patients a smartphone, but they also have separate readers that you can get. Previously, older models often required confirmatory testing before making treatment decisions, but most of those, except for one, are not that type anymore. And then they can be used independently, or they can be integrated into various insulin pump systems like the Omnipod. For some additional terminology, there are therapeutic and non-therapeutic systems. The therapeutic ones do not require calibration with finger sticks before being able to use them. And then there are also intermittently scanned, real-time, or retrospective systems. And a system that's intermittently scanned doesn't automatically push the readings to the reader or the receiver. Real-time systems do. And a system can be real-time and therapeutic, or it could be intermittently scanned and therapeutic. And so the ones with the arrows are what we're mostly talking about as we go through the rest of this review. So we go to the next slide. I did find 4 different guidelines I wanted to highlight that specifically call out use of CGMs, but it's not specific to one branded product or another. Out of the UK, the NICE guidelines do recommend the use in patients with type 1 diabetes of a real-time CGM, preferentially over an intermittently scanned one in children, or either of those in adults. And then in patients with type 2 diabetes who have additional risk factors like multiple daily insulin injections or things like recurrent hypoglycemia, they do recommend the intermittently scanned products unless real-time monitors are available for a similar cost. In patients who are pregnant or with gestational diabetes and take insulin and have other concerning things like problematic hypoglycemia, you can consider use of a real-time CGM in those patients as well. And then SIGN, the Scottish guidelines that were specifically on patients who were pregnant, do recommend use of CGM in those with type 1 diabetes during pregnancy, and to consider it in those with pre-existing type 2 diabetes. There's insufficient evidence for across-the-board use of CGM and gestational diabetes in just all patients. If you go to the next slide, there's two more I wanted to highlight. One is the VA, and in their diabetes guidelines, they acknowledge that some of the studies for CGMs have shown improvements in things like A1C or reduction of hypoglycemia, but they encourage more end-outcome data like hospitalizations and reductions of microvascular and micro and macrovascular complications. And then finally, CADTH out of Canada did a review of guidelines specifically on the real-time monitors. And the general recommendations they found across their own review of guidelines were recommendations for using CGMs in adults with intermediate to high quality evidence, and supporting recommendations for use in children and young people who have type 1 diabetes. And then for those with type 2 diabetes, they support use in some patients. It's generally what I listed on the other page, those who take insulin as well as having hypoglycemia, hypoglycemia unawareness, things like that. And then the data in children were lacking. And so if you go to the next slide, HERC has reviewed this topic in the past, and I think the most recent update was in 2024 when they added some conditions for type 2 diabetes. But the guideline note 108 recommends coverage, and this is what the medical unit uses, for those with type 1 diabetes to use a real-time CGM if they have one of the additional risk factors of a baseline A1C above 8, frequent or severe hypoglycemia, an insulin pump, plan to become pregnant in the next 6 months, or people who are under 21. And those who have type 2 diabetes, gestational diabetes, or diabetes due to some other condition like steroids, and who take a rapid or intermediate acting insulin and have one of the additional risk factors, they also recommend use of access to a therapeutic CGM. So that could be an intermittently scanned or real time. And then those with the rare condition of glycogen storage disease 1A, they list access for a real-time CGM. And if you want the exact nuance of the guideline note, it's in the appendix. All patients are supposed to receive education as well. And there's some other nuance in how it's worded, but that's in the appendix. If you'll go to the next slide, Kathy's already gone over this, but just generally speaking, because we're going over many more devices than just Omnipod, the older CGMs, many of them that were non-therapeutic, went through pre-market approval, and then some of the subsequent ones used the 510K to be to get approved as a predicate device on the older ones. One of the more modern ones that I'll point out went through the de novo pathway, and then several of the other modern ones have used a 510K pathway to use it as the predicate device. And so comparing a CGM from 10 years ago, it's a little different than now, but these pathways and these pre-market approvals, they compared it to finger sticks. We weren't comparing outcomes like A1C or anything like that. They were comparing it to lab-drawn finger sticks done in a clinic between the different devices. Now, if you go to the next slide, because of that, and because I was unable to find direct comparative evidence of the current systems that are used, and they're pretty different from iteration to iteration, in studies that were large enough size or with clinical outcomes that we cared about, were down to mostly pragmatic details. But the Dexcom G6 I wanted to mention is the product that went through the de novo pathway. It's a real-time CGM. It does have some integration with other devices and a sensor duration of 2 years. The Dexcom G7 and the Freestyle Libre 2 both used it as the predicate device for approval. Dexcom CGM is also a real-time CGM. It has a 10-day sensor duration, but a 15-day sensor has been approved for adults. It should enter the market soon. The Freestyle Libre 2 was an intermittently scanned device initially, and they've updated it so that it can give patients a high or low alert without having to scan the device. So it's kind of, I think they still have to scan the device to get all of the sensor readings, but they do push high-low readings. And the plus sensors on the 2 and the 3 are smaller, and they're approved for younger age groups. Freestyle Libre 3 is a true real-time CGM as well. Freestyle 14-day is an intermittently scanned device. The transmitter has been discontinued and it's, I think, phasing off of the market. And then to compare the Guardian and the Simplera devices, the Guardian devices are not standalone CGMs because the app that was used for that has been discontinued. They're only integrated with Medtronic pumps, and the Guardian 3 requires calibration twice a day. The Simplera Sync also has to be used with a Medtronic pump. The Simplera is a standalone device, but as you can see, it's only approved for those over 18 years old, and it does have a sensor duration of only 7 days compared to some of the longer ones that you can see below. If you go to the next slide, just generally as far as clinical safety, you can have some inaccuracy with higher doses of some of the agents listed. Generally, therapeutic doses of acetaminophen don't throw off the levels, but higher doses can. Different devices, you need to check labeling before using it with different kinds of imaging scanning, and use around high voltage electrical equipment can interfere with the operating systems. And then finally, skincare products like sunscreen or insect repellents in certain patients that can affect the system components and its ability to be accurate. After you go to the next slide, I wanted to mention 2 important safety recalls. Kathy mentioned one briefly, but the first one, which I think is really important because we think of these systems as being easier for some patients. Patients who are using their smartphone as readers have noticed problems with operating system and other updates that change things like your device do not disturb settings or focus settings, where it changes the alarms for these devices. And so you really need someone who's savvy enough to know how to use their smartphone as well. Even just connecting with your car or your headphones can change some of the alert volumes. And so that's actually something that highlights that patients also need access to a normal finger stick device if they are using a CGM. Additionally, there was a recall of some of the Freestyle Libres for inaccuracy about a year ago. Okay, go to the next slide. So just to summarize, initial approvals were based on comparisons of the accuracy of finger stick measurements. Later approvals are generally based on substantial equivalent to an existing CGM, still using finger sticks also as a comparison. There's not sufficient comparative evidence between the specific branded products. New products are entering the market quite frequently, and there are a lot of software updates with how alarms are set and things like that that are introduced in the marketplace that make it difficult to compare them. But the systems from Dexcom and Freestyle do offer some pragmatic advantages as far as the approval age for those that can use it, the sensor life, and then some of the compatibility with the insulin devices. So if you go to the next slide, we do have existing prior authorization criteria modeled off the medical side before this was under the peer review of the P&T committee. I did want to add the note for requires PA. There is an automatic prior authorization in place for those select patients with type 1 and type 2 diabetes who are already on short-acting insulins. I've updated table 1 with some of the newer systems that are on the market. And if you go to the next slide, I do want to make one change on this page. This is pre-existing based off of the guideline note 108, but on question 6, it's going to go, a yes will go to question number 10. But all patients have to get on question 4, diabetic education. That's part of the guideline note. If you have type 1 diabetes, you need an additional risk factor as delineated in number 6. And then if you go to the next page, if a patient does not have type 1, but has type 2 or gestational, then you would go to question 8, which is also based off of the guideline note. Any of the patients that have yes to both of those, they'll go to question 10, but there is also the guideline note does allow for use in glycogen storage disease. So those patients, I wanted to add that question. Then all of those would go to number 10, and now we can make a preferred drug list. And so we're making edits to be able to make preferred products or non-preferred products. Based off of that and based off of the possibility of making some products preferred that may not be, that may only be compatible with certain pumps that a patient is already using, I added question 11 to make the ability for a patient using a specific pump to get a product, even if it's not a preferred product. And I will change the formatting on that so that it does go all the way across. And then if you go to the next slide, this is the renewal criteria that was pre-existing, and it's based off of guideline note 108. So the recommendations right now are no changes to preferred drug list. All of the products are currently in the system as preferred. based off of the clinical data, and to approve the prior authorization with the proposed changes, and to continue the auto PA that we have, and as well as evaluate costs in the executive session. So, are there any questions?
Nice job, Sarah. And we do have public comment. Questions for Sarah? Hearing none, Gary Pronto with Dexcom, are you able to unmute your line?
Yes, can you hear me?
Hear you loud and clear, Gary.
Excellent, excellent. Thank you. Hello, my name is Gary Paranto. I'm the National Account Executive with Dexcom, the maker of Dexcom G6 and G7 real-time CGM devices, both approved as replacement for finger sticks in patients 2 and above, as Sarah eloquently noted. She also noted that Dexcom is going to be bringing in a 15.5-day version of G7. It should be coming out sometime this quarter. We're expecting the end of this month for the DME side and December 1 for the pharmacy side. And that would be indicated for adults, the added value of having the longest lasting CGM on the market, as well as having a MARD, which is the accuracy measurement, best in class at 8%. Anything under 10 is considered really good, and all the real timers are in that mode. So that's a good thing. MARD means mean absolute relative difference, and it's considered the gold standard for accuracy. Lower the MARD, the better the glucose data. So CGMs have been game changers, as you know, when it comes to making meaningful changes in patients' lives, when it comes to hemoglobin A1Cs, as well as time and range, and truly changing the behaviors leading to reductions in hospitalizations and ER visits due to hypoglycemia. It's actually a trial I just wanted to call out by Dr. Garg from the Barbara Davis Center in Denver. It's a 75,000 real-world patient study population, and it was published in Diabetes, Obesity, and Metabolism late last year. Basically, it was measuring healthcare utilization, and those were reduced across the broad range of different types of patients. So there's 75,000 patients. Some were on prandial insulin, some were on basal, and some were on no insulin. And basically, what we saw within a year's time, all of them had statistical reductions when it comes to diabetes-related hospitalizations. There was a 48% reduction for basal, as an example, and that's, of course, the benefit that CMS uses. They kind of go with a any insulin type requirement when it comes to putting patients that are going to truly benefit from the CGM technology. Prandial had a 53% reduction, and then patients that weren't on any type of insulin but were diabetic had a 31%. So good trial for you to take a look at. It comes down to really engaging patients as far as CGM and what they can offer. So Dexcom real-time CGM, glucose data to receiver is a smart device with any action required by the user. The biggest differences we have versus Libre is when it comes down to the different types of attributes of the product, we've got a situation where urgent low soon delay is there, as well as no need for finger sticks. And certainly the pump patients have the share and follow for 10 patients that can share with the loved ones. Thank you so much for your time. I just ask that you continue to keep Dexcom on the front line and even consider it for basal patients as well. Thanks.
Thank you, Gary. Any questions from the committee for Gary, particularly about the Dexcom products? Okay, the recommendations are back up in front of you. No changes to PDL based on the clinical data. Approve the criteria as proposed and continue to do the auto PA. And we're going to look at costs in executive session. Discussion or a motion?
I just want to double check that I'm sorry, the short acting insulin in addition to basal, double checking that is a requirement for a CGM to be approved on this criteria.
Correct.
That I would like to discuss a little bit more, because I do think that patients on basal insulin. I have so many patients on basal insulin that would really
Yeah, but this
benefit
is
from that.
this is a coverage guideline by HERC. Short or intermediate acting.
Okay.
That is what this criteria is based on for sure. And they did a pretty extensive review. And we didn't find any evidence for the intermediate or the basal acting insulin based on Sarah's review that we considered to be high quality, but it is something I think that this committee can discuss for sure.
I would caution this committee from trying to come up with different criteria than the HERC at this time. It's a fool's errand.
Well, and I guess the question is, the motivation for coverage for people who are not using short or intermediate acting, I mean, from a safety perspective,
Exactly.
right,
How does it actually change their therapy? I mean, I don't see any logic.
I have
Yeah, I mean, the
patients with
the
eating
hypoglycemia risk, I think, is a driving factor for coverage for folks with type 2 diabetes.
Understood.
Which is going to be
that's
greater for folks on
part of
short
the-
and intermediate acting.
That's part of the guideline now.
The guideline note for anyone who wants to see it is on page 273. These do mirror that and would mirror how patients access this through the medical benefit. And just to Dr. Stevens, to address part of your question, when HERC opened coverage and they did their literature review, they were also using some of the information that had come out of Medicare when it was being opened for CGM for certain Medicare patients.
Thank you. I think where my concern comes is there's actually quite a large overlap of patients with eating disorders and diabetes. And you start running into issues with short and intermediate acting insulins where you're asking someone with an eating disorder to carb count to dose units of insulin. And that can create a lot of challenges in diabetes management, where I think myself and other providers often will do as much as you can with a basal, and a CGM does still benefit you there in that in getting more information while not triggering the patient into not eating, which worsens their diabetes.
In that situation, though, wouldn't that be something that, I mean, I'm not saying it's easy, but in that situation that you're describing, I think that would be something where you could, appeal if the PA got denied or didn't meet criteria. I feel like an appeal likely would be successful. I don't know that for sure, but it feels to me like in those extenuating circumstances, there's going to have to be some conversation, but it's probably not, if you look at the number of type 2 diabetics on basal insulin, I think probably the majority of them are not going to fall into that category, right?
Nearly all of my patients that are on insulin could meet clinical criteria for an eating disorder.
Okay.
Well, I would say that you have a very unusual practice.
I do have an unusual
telling you
practice,
that
but
that
there's
is not
also
the
a
case.
lot of eating disorders in diabetes. And I'm sure any endocrinologist would attest to that.
I think this is great. Show up at a HERC and submit information there. The problem that we have here is we're looking at pharmacy criteria for the same thing that the DME companies that HERC creates the criteria for. So we can't have two separate, well, you can have different criteria for the pharmacy that from a DME company. That's the rub.
So I'm sorry, just to be clear, if we can't have different criteria, what are we doing?
What?
Like if we're able to entertain the conversation, but we have to have the same criteria no matter what, is that a correct understanding?
We're creating, yeah, we would be creating a big mess that we would have to have a big sit down between the P&T committee and the HERC, and you know, for a minority of your patients, a minority of the entire patients, maybe your majority, but I'm going to tell you that is extremely unusual. As an internist, 40 years, that we're not, you know, a majority of my type 2 diabetics did not have eating disorders.
Respectfully, sir, I would argue that that might not actually be the case.
If I can chime in, one common thing we're talking about, I think basal insulin patients and like the benefit of maybe finding out when they go hypoglycemic versus hyperglycemic for adjusting their basal insulin. It's often, not often, but patients can have Somogyi effect or rebound hyperglycemia. And so kind of checking and seeing that. So I think that number 8 on our criteria would often catch patients that potentially have an eating disorder that will lead to hyper and hypoglycemia, especially in light of basal insulin that makes you more prone to the hypoglycemia when someone has over 8 carbs and had that rebound Somogyi effect. So that would catch a good number of the patients that I think we're talking about just because of that.
I think to clarify, if a patient isn't on a short or intermediate acting, you would bypass number 8 and just check if the patient had a glycogen storage disease. So if you were just on a basal, it would go to appeal, I think would be the best way for those particular patients who might have some extenuating circumstances and aren't on short acting.
And there is a lot of discussion around this. And so maybe the best option is for us to do some more research and bring this back as a topic, talk with HERC, because they did help develop this criteria, and bring it back to you all for further discussion.
Well,
Yeah, I think that's
I'm
a good
ready to move for approval of the PA criteria as recommended by the staff. And then if we want to sort it further, we can do it after the fact.
Okay, so we have a motion. Do we have a second?
I'll second. This is Bridget.
Okay. All those in favor?
Aye.
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 Okay, opposed? Abstain? Okay. All right. So it sounds like this passes the way it is, but we'll continue to have conversations with HERC, and if they decide to make changes, or if there is, you know, more evidence that makes us want to change the coverage around folks on basal insulin, we could readdress it at a later time. Is that, Roger, am I getting that?
Yep, you're getting that. I think we'll definitely work with Samara, get any, if she has any literature in that space, particularly cases, we'll look at that, work with the HERC, and at a minimum, I think it's going to provide us, when I'm talking about me and my team, a useful platform from which we can adjudicate PA reconsiderations, because that at this time would be the pathway for us to consider that. So it's compelling, but I'd like to look into it a little bit more, and appreciate moving forward with what we've got, so we have something that we can get in the PA guide, and we will not drop this. We'll churn some more on it. So I appreciate you speaking up and sharing that with us, Samara, and what you're doing for your members and your patients. So thank you.
Yes,
Thank you.
thanks. It's an interesting in-between space where we have medical coverage and pharmacy coverage, but also the medical HERC guidance doesn't specifically name certain products. And so it's a new space for us. And so we appreciate the feedback.
Thank you all.
Thank you.
Yeah, and
Time
thanks.
check. I know one of the two of the committee members have a constraint that they're going to have to drop off right now. We have all 11 members here today, which is phenomenal. So the bar of meeting our a quorum to continue to take votes is met easily. The question is, should we defer the last two topics because we have a lot to go over in executive session, or can we squeeze one more in, 10 to 15 minutes to do the sleep-wake medications? Anybody, whoever speaks up first, what's the consensus? Might put us over a little bit, might be like 5:10, 5:15 by the time we ring the bell and we're done. Is that okay with everybody? I'm not hearing anything either way. Tim, I appreciate it. Eddie, all right, I'm hearing, anybody opposed? All right, let's move on to page 279. This is going to be the last topic for the day. We're going to defer the antifungals. If anybody in the audience was hanging out just to hear about antifungals, I'm sorry. You'll have to wait for December. But right now, Dave Ingen, we'll turn it over to you, page 279 if you're following in the packet.
Okay, thank you very much. Yeah, so today I'll be presenting an update for the sleep-wake medication class. More specifically, we'll evaluate efficacy and safety of medications that are used to treat central disorders of hypersomnolence and other conditions that cause excessive daytime sleepiness. Previous reviews found no clinically significant comparative differences in efficacy or harms between agents for narcolepsy, and there was insufficient evidence on either important health outcomes or off-label doses to warrant changes to the PDL. And there was also insufficient direct evidence to evaluate comparative efficacy or safety of modafinil, armodafinil, or other stimulants for shift work disorder or in circadian rhythm sleep-wake disorders. On the current PDL, modafinil and armodafinil are preferred. Solriamfetol is voluntary non-preferred, while pitolisant and sodium oxybate formulations, physical health drugs, are non-preferred. And all agents in the sleep-wake medication class require prior authorization. And we do allow auto approval for modafinil and armodafinil when they're used for narcolepsy at FDA-approved doses. So EDS, it's the inability to remain awake and alert during typical hours of wakefulness. It's found in patients with narcolepsy, with or without cataplexy, obstructive sleep apnea, and shift work disorder. Other medical conditions where patients struggle with hypersomnia include MS, Parkinson's disease, traumatic brain injury. There's also idiopathic hypersomnia. It's characterized by EDS symptoms that can't be explained by another disorder. EDS treatments, they're tailored to the underlying cause. For narcolepsy, treatment usually involves a stimulant medication, but approved use is very nuanced based on the presence of cataplexy and the age of the patient and so forth. While in OSA, it's essential to treat the underlying condition with CPAP therapy and use stimulants as adjunct therapy if needed. For other conditions such as shift work disorder, treatment is usually multimodal with heavy reliance on sleep hygiene and non-pharmacologic therapies. There's some different scales that are used to assess baseline EDS and the effectiveness of different therapies. Some of the more common ones are found in the literature are the Epworth Sleepiness Scale, Maintenance of Wakefulness Test, and the Fatigue Impact Scale. And as you can see in the table, each tool has different ranges, minimal clinically important difference values, and may be more appropriate for certain situations or diagnoses and patient populations. But if we look at the systematic reviews, There were some systematic reviews published in this space since the previous class update. There's a Cochrane review, and it investigated medications for daytime sleepiness in individuals with idiopathic hypersomnia, and found that treatment with modafinil resulted in a significantly lower ESS score at 3 weeks compared to placebo, and this was based on high-quality evidence. And a systematic review that was published in 2024 assessed the use of modafinil for treatment of fatigue and multiple sclerosis. There's moderate quality evidence that found compared to placebo. Modafinil reduced fatigue as measured by the MFIS. It demonstrated modest but statistically significant improvement in the ESS score, resulted in improved physical quality of life score, but also reported a higher risk of an adverse event with modafinil use. So yeah, that's for the systematic reviews. Let's move on to the guidelines. In guidelines published by American Academy of Sleep Medicine, pharmacotherapy was evaluated for a number of conditions. See there, such as narcolepsy for adults and children, idiopathic hypersomnia, hypersomnia due either to PKD, MS, or TBI. Basically, there were strong recommendations in favor of using either modafinil, pitolisant, solriamfetol, or sodium oxybate in the treatment of adult narcolepsy. Modafinil also received strong recommendation in the treatment of idiopathic hypersomnia. The rest of the agents and conditions had either conditional recommendations or were not addressed due to limited evidence. A few more guidelines to go over. There are some semi-recent guidelines published by NICE recommending the use of modafinil in PKD or MS, but only after careful patient evaluation and assessment of risk and benefit. There's also the VA, DOD, they addressed management of OSA and suggested that adding modafinil, armodafinil, or solriamfetol to treat OSA-related residual excessive daytime sleepiness is warranted. But in patients who are first optimally treated with sufficient primary therapy, so mainly like positive airway pressure devices and such. So it did qualify that. If we look at safety, there were some updated safety labeling changes noted for a handful of these agents. Warnings involve adverse events specific to each agent, various drug interactions and precautions in certain populations, such as pregnancy or when breastfeeding. For more information, I would direct you to the write-up or to the most recent manufacturer label on the FDA website. Pitolisant, solriamfetol, and all sodium oxybate formulations, they had updates regarding pediatric restrictions grouped by specific age, and I'll cover that in the next slide. And I'll try to group these together by drug for time's sake. So in October 2018, Xyrem received expanded approval for treatment of cataplexy or EDS in patients 7 years of age or older with narcolepsy. And then the related cousin, Xywav, received expanded approval for treatment of idiopathic hypersomnia in adults. And then skipping to Lumers, May 2023, extended release. It's an oral suspension, received approval for treatment of cataplexy or EDS in adults with narcolepsy. And then in 2024, received expanded approval for treatment of narcolepsy in patients 7 years and older. And then for pitolisant or Wakix, received expanded approval for treatment of EDS or cataplexy in adults with adult patients with narcolepsy. And then in 2024, it also received expanded approval for treatment of EDS in pediatric patients 6 years of age and older with narcolepsy. So the recommendations based on the review, add all sodium oxybate formulations to the sleep-wake medication class on preferred drug list, review comparative costs of the sleep-wake agents in executive session, review and update PA criteria that we'll go over in a minute as proposed, and apply criteria to all sodium oxybate formulations. So if we do look at that criteria, just some really pretty straightforward updates. In the table, you'll see we updated it to include new FDA-approved or evidence-supported indications. So really, that's all that was done to that table. If you go to the next slide, for table 2, we added a spot for sodium oxybate preps. And then in table 3, we added some precautions to note with sodium oxybate products. And that's right off of the labeling. If you go to the next slide, question 7, we add some clarifying language and list some of our preferred agents. Then in 15, we add clarity to what's meant by appropriate CPAP compliance. And then lastly, in our renewal criteria question 5, we add the statement or other covered conditions just for more clarity. And really that is it for that class review, and happy to take any questions.
Thank you, Dave. Questions for Dave? All right, do I hear a motion?
Motion to approve.
Thank you, Samara.
Second.
Thank you, Eddie.
All right. All those in favor?
Aye.
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 Opposed? Abstain? All right. Thanks, everybody. And thanks, Dave.
Thank you.
Good job. As I said, we're going to defer the antifungal class. We have a bit to go over into exec session. We're going to open up a breakout room. I need to read a blurb. No timing. I don't think I'm feeling very fast today, but nonetheless, here we go. The P&T committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. Executive session is held pursuant to ORS 192602F and ORS 414-356-1 and 2, which allows the committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class that's necessary for the committee to make final recommendations or comply with the requirements of ORS 414-353. Representative of the news media and designated staff shall be allowed to attend the executive session. All other members of the audience are not permitted to attend. Representative of the news media are specifically directed not to disclose any of the deliberations during the executive session, except to state the general subject of the session is previously announced. No decision may be made in executive session. At the end of the executive session, we'll return to open session and make recommendations. All right, going to pause the recording and we'll be back. All right, we are returning from executive session. Give us a second to get situated, take our phones off of mute. I'm going to chip away at these one by one. If the committee can come off mute, we'll tee these up and take one recommendation at a time. Fantastic. So first class in front of us is the was part of the consent agenda, the iron replacement based on the oral literature scan. The recommendation is to make all single ingredient iron products that cost less than 25 cents per preferred